Welcome to another MedCram COVID.
Actually, let me fast forward this. It's a long video. Okay, here's the beginning of the hypothesis once again. We might as well just see that one more time.
I wanted to continue our discussion about ACE2 and superoxide. So we said that superoxide was a bad thing, that it caused endothelial dysfunction, the endothelium being the lining of your vasculature. And we said that there were a number of things that happened when ACE2, this enzyme that was inactivated by SARS-CoV-2, went down. Because ACE2 converts angiotensin 2 into angiotensin 1,7. When you lose ACE2, you accumulate angiotensin 2, and that causes a stimulation of superoxide. When you lose angiotensin 1,7, you lose the inhibition of the creation of superoxide. Also, SARS-CoV-2 directly will increase superoxide because it recruits PMNs, and those are a certain type of white blood cell. Now, going on up here, we have angiotensin 1, which is converted to angiotensin 2 through the ACE enzyme. And so ACE inhibitors inhibit ACE, and what they do, in addition to inhibiting ACE, is they also tend to increase ACE2, which is the enzyme that we just talked about. And ARBs will block the effect of angiotensin 2 on the creation of superoxide, but ARBs may also increase the amount of ACE2. The bottom line is understanding that when you have a SARS-CoV-2 infection, you're going to get increased endothelial dysfunction. So let's see what happens when that occurs. And we've looked at this paper before that was published almost 20 years ago out of Boston University School of Medicine. It describes how all of these things come together with endothelial dysfunction and reactive oxygen species that we've talked about. And if you lose some of these protective mechanisms like superoxide dismutases, glutathione peroxidases, catalase, and glucose 6-phosphate dehydrogenase, then you're going to get increased oxidative stress. And we've shown you those things here before. Here we have an increase in superoxide, and it takes superoxide dismutase to reduce it back to oxygen and hydrogen peroxide. And then through glutathione peroxidase, you can reduce hydrogen peroxide back to water. Through catalase, you can reduce it back to oxygen and water. And there's ways of recharging all of these things. For instance, zinc, copper, and manganese is essential for superoxide dismutase. And certain types of antioxidants can reduce glutathione peroxidase. What's really important in normal endothelial function is this molecule called nitric oxide. In fact, nitric oxide is how angiotensin 1,7 works. And so we've gone over this stuff before, but the focus of today's talk is thrombosis. And so there are well-established papers taking endothelial dysfunction, or ECD, and connecting it with thrombosis. And it also connects it through the bioavailability of nitric oxide. It says here that deficiency of these enzymes, like for instance the superoxide dismutases, glutathione peroxidases, increase oxidative stress and nitric oxide inactivation, and as such can lead to endothelial cell dysfunction or account for the underlying mechanism of endothelial cell dysfunction associated with a given atherothrombotic risk factor. So those things are connected: oxidative stress, nitric oxide, endothelial cell dysfunction, and thrombosis. And so the question comes up: is there oxidative stress occurring in COVID-19 infection? And it seems almost assuredly that because of the fact that it affects the ACE2 receptor and enzyme, there is going to be oxidative stress. And the second question is, how does it affect thrombosis? Well, there was an article that was published on April 15, 2020 in Thrombosis Research, and it describes a patient who came in and what happened with their coagulation factors. And what it showed was that there was a massive elevation of this von Willebrand factor. And this von Willebrand factor, the antigen was 555% of normal. And the von Willebrand factor was 520% of normal activity, when normal is 42 to 168. There were also other factors that were increased, including factor 8 of the coagulation cascade. And even they realized that the increased von Willebrand factor points towards massive endothelial stimulation and damage with release of von Willebrand factor from Weibel-Palade bodies. Interestingly, endothelial cells express ACE2, the receptor for SARS-CoV-2, thus possibly mediating endothelial cell activation. So you're probably wondering what these Weibel-Palade bodies are. They're only found in endothelial cells, and these tiny little bodies release these stringy type substances called von Willebrand factor, which allows for coagulation, and it allows platelets and the clot to form together. When there's so much destruction of the endothelial cell, this von Willebrand's factor is released in high concentrations into the blood. Here's another article that was published in 2017 titled Endothelial Cell Von Willebrand Factor Secretion in Health and Cardiovascular Disease. And notice what it says here in the abstract. The main function of von Willebrand factor is to initiate platelet adhesion upon vascular injury. The hallmark of acute and chronic inflammation is the widespread activation of endothelial cells, which provokes excessive von Willebrand factor secretion from the endothelial storage cell pool. The level of von Willebrand factor in blood not only reflects the state of endothelial activation early on in the pathogenesis, but also predicts disease outcome. And this is key. Elevation in the blood level of von Willebrand factor occurs either by pathological increase in the rate of basal von Willebrand factor secretion or increased evoked von Willebrand factor release from dysfunctional or activated endothelial cells. And that's exactly what we see here, we believe, in COVID-19. The increase in plasma von Willebrand factor is predictive of prothrombotic complications and multi-organ system failure associated with reduced survival in the context of severe inflammatory response syndrome, type 2 diabetes mellitus, stroke, and other inflammatory cardiovascular disease states. This is exactly what we're seeing in COVID-19. This chapter focuses on the role of high circulating von Willebrand factor in thrombotic and inflammatory disease, while paying attention to the emerging von Willebrand factor related drug development strategies. They go on to talk about how von Willebrand factor is a surrogate marker of endothelial cell dysfunction. The highly multimeric, that means many of them all together, elongated form of von Willebrand factor is not present in healthy plasma. So they don't see a lot of this highly multimeric form in healthy plasma, but is found in various pathological settings. This observation can be explained by the fact that von Willebrand factor senses shear forces and remodels accordingly. Atomic force micrographs have demonstrated at the single molecule level that under static conditions, von Willebrand factor assumes a globular conformation, whereas under high shear flow, von Willebrand factor turns into an extended chain format that forms ultra-large strings to which platelets can bind and initiate clot formation. This is what we're seeing in COVID-19 at sites of vascular damage and when shear stress is above 30,000 per second. Factor 8 is released from its carrier protein to provide factor 8 to the coagulation cascade. This is exactly what we saw in the article that described the COVID-19 patient. We now realize that while ultra-large molecular weight von Willebrand factor is essential for the normal hemostasis, this multimeric array should not become too large because it alters the thrombotic propensity. Now notice what they say here. In conclusion, excessive levels of highly prothrombotic and multimeric forms of von Willebrand factor and or ADAMTS13 deficiency, and this ADAMTS deficiency has to do with the platelets, but specifically what ADAMTS does is it cleaves and cuts up von Willebrand factor. And believe it or not, it's a zinc-containing metalloproteinase enzyme. And so essentially ADAMTS reduces the effectiveness of von Willebrand factor. But this is a unifying pathological mechanism linking inflammation, oxidative stress, and thrombosis. So let's review up to this point. We have SARS-CoV-2, which causes an infection, and that reduces ACE2. And the reduction in ACE2 is going to increase angiotensin 2 and decrease angiotensin 1,7. That together is going to increase oxidative stress with superoxide. That, as we've just talked about, is going to cause endothelial cell dysfunction. Endothelial cell dysfunction leads to an increase in von Willebrand's factor, which eventually leads to thrombosis. Now, there's a lot of dots to connect there, but again, we see that SARS-CoV-2 is a virus which attacks the ACE2 receptor, and that is the entry point. When it attacks the ACE2 receptor, it takes out of commission its catalytic site, and it is no longer able to convert angiotensin 2 to angiotensin 1,7. As a result, you have an increase in angiotensin 2 and a reduction in angiotensin 1,7. In addition to recruiting neutrophils, that causes increased superoxide creation, and that increase in superoxide creation causes endothelial cell dysfunction through a nitric oxide pathway. Because there are bodies in the endothelial cell that contain von Willebrand's factor, that gets spilled out, as we saw, up to 500% increase in its activity. And that increase in von Willebrand's factor through a number of complicated interactions is going to cause an increase in thrombosis locally where the inflammation is occurring. Now let's just connect those dots here because it's interesting. We know that ACE2 is involved in the infection. We know that ACE2 causes this pattern. We know that this pattern does cause an increase in superoxide. We know that superoxide and oxidative stress is going to cause endothelial cell dysfunction, which is going to release these little bodies inside that will increase von Willebrand's factor. We know, based on information and case reports, that we see an elevation in von Willebrand's factor, as we showed you here in the first article. And we can see here that von Willebrand's factor can cause an increase in thrombosis. And we also have good data that shows on autopsies that SARS-CoV-2 increases the amount of thrombosis. So yes, we are connecting the dots here. We don't know for a fact that this is happening in patients with COVID-19, but it seems very likely that this is the case. Let's take a look at some more data. You may remember back in March of 2020, there was some stir about the different blood types and whether or not the blood types would lead to a prognosis in terms of getting the COVID-19 infection, hospitalization, or even death. This is the study, and it actually came out of China. And let's take a look at some of the numbers that they found. In one of the studies, they simply looked at the general population in a community. And they looked at type A, B, AB, and O. And they found that in the population of 3,694, 32% were type A, 25% were type B, 9% were type AB, and 34% were type O. Then they looked at those that were admitted to the hospital with COVID-19. And so these are COVID-19 patients that are positive, but not just positive, but sick enough to actually be in the hospital. And what they noticed was that A went from 32 to 38%, B went to 26%, AB went to 10%, but O went to 26%. There was a drop here statistically significantly in type O. Then they looked at those that had actually died. And these were in 206 patients. The COVID patients that were positive were 1,775. So in those that died, 41% were type A, 24% were type B, 9% type AB, and 25% were type O. Again, statistically significantly lower. And they looked at several other populations in this study, and it held true across the board. In fact, they also felt that type O blood actually helped in terms of reducing the actual infection or entry of the virus into the cells because of antibodies. Now, key point, this paper at the time that it came out was not peer-reviewed. And as far as I know, it still has not been peer reviewed. If somebody has information on that, I'd certainly love to hear it. We could also do some peer review on it here. But what I find really interesting is this peer-reviewed article from 2007, which clearly shows that there are a number of relationships between ABO blood group and von Willebrand factor levels. Yes, the same von Willebrand factor levels that we say might be tied in to our hypothesis. In the article, it states very specifically that several studies have documented the influence of ABO blood groups on plasma von Willebrand factor levels. In a large twin study, they found that 66% of the total variation in plasma von Willebrand factor levels was genetically determined, and that 30% of this genetic component was explained by the ABO blood group. Other studies have consistently reported that, and here it is, Group O subjects have lower plasma von Willebrand levels than non-O individuals. So the question is this just a coincidence? Because it very well could be. Or is it possible that Group O subjects have less of an increase in von Willebrand factor levels and therefore have less thrombosis and therefore have less of a mortality in COVID-19? That is just speculation at this point, but it's an interesting hypothesis that could be tested. There's also a determination between ABO blood group determinant and the ADAMTS13, which we talked about before. Remember that ADAMTS13 is what cuts up the von Willebrand factor. Interestingly here, it says that monomeric analysis and collagen binding assays both demonstrated that proteolysis, that means the cutting up of those von Willebrand factors that could be dangerous, was significantly faster for Group O von Willebrand factor compared to non-O von Willebrand factor. There's also been a discussion about the fact that there are certain racial and ethnic minority groups that are overrepresented in terms of COVID-19. Specifically, it says here at the CDC, 33% of hospitalized patients were Black compared to 18% in the community. It goes on to say, these data suggest an overrepresentation of Blacks among hospitalized patients. They also noted that Black or African Americans had death rates that were substantially higher than that of white or Asian persons. Now, when we go back to this article, it states here that Miller and colleagues studied the effect of ABO blood type and race on plasma von Willebrand factor levels and found that Caucasians had significantly lower levels than African Americans. Could this also be by coincidence? It's possible that whatever affects the level of von Willebrand's factor may be a risk factor for increasing death from COVID-19, but it could also be a coincidence. So why are there lower von Willebrand factor levels in blood group O? And it seems as though, according to this article, blood group O, for some reason, increases the clearance of von Willebrand's factor. So it very well may be that this increased von Willebrand factor is what is causing the thrombosis. And there are several mediators of this increased level of von Willebrand factor, not the least of which could be ABO subgroup types. So it would seem reasonable that if we were to put patients on anticoagulation, we might be able to reduce the risk of death. Well, enter this paper that was just published last month on April 27th. This article is titled, Anticoagulant Treatment is Associated with Decreased Mortality in Severe Coronavirus Disease 2019 Patients with Coagulopathy. And what they found was that in all comers, they didn't notice any difference in 28-day mortality in multivariate analysis. However, when they compared those patients that were sicker, they had 6 scores greater than 4, and they also had D-dimers greater than 6-fold of the upper limit of normal. They did notice that there was a statistically significant improvement in patients who were on anticoagulation, with a p-value of 0.029 and 0.017. And so their conclusion was that anticoagulant therapy, mainly with low molecular weight heparin, appears to be associated with better prognosis in severe COVID-19 patients meeting SIC criteria or with a markedly elevated D-dimer. Now remember what the D-dimer is. A D-dimer is a marker in the blood that shows that coagulation and breakdown is occurring. So this is the hypothesis. This is what may be going on. We don't know for sure, but it seems as though the dots are connecting themselves here almost. SARS-CoV-2 causes a decrease in the ACE2, which causes an increase in angiotensin 2 and a decrease in angiotensin 1,7, increasing oxidative stress, causing endothelial cell dysfunction, increasing von Willebrand's factor, leading to thrombosis. So what do we do about it? Join us next time while we talk more about this topic, and join us.
Okay, there's one more. Sorry, I should have done something earlier to get these all lined up. The way von Willebrand's factor works, that's what I need to show in the next video. So let's see, that was this one.
When I first saw this product, I thought it looked kind of crazy. Didn't really understand what the benefits would be, but
Actually, I'm a subscriber to the site, so I could get rid of those, but let me just see the von Willebrand's factor here. This has it in there. There. All right, this is the one.
Of recharging glutathione and improving oxidative stress in some of these respiratory illnesses. And for a full comprehensive review of that, I recommend that you look at Update 69. One of the important things that we talked about was glutathione. And if you don't know, glutathione is actually 3 amino acids put together. The middle one is cysteine, and it's right here. It's the part that holds this SH group, which we talked about last time, which is a reducing agent. On this side over here, we have glycine. And on this side over here, we have glutamate. But glutamate's not attached to the normal C that it would normally be attached to in a polypeptide chain. It's actually attached to the gamma carboxylate group, which is down here. But nevertheless, there are 3 amino acids which make up glutathione. The other part that I wanted you to know is that this part right here, which is the glycine and the cysteine residue off to the right, is N-acetylcysteine. So you can clearly see how N-acetylcysteine is one of the precursors to glutathione. And that's important because we talked about giving N-acetylcysteine as a way of recharging this SH group in patients with oxidized glutathione. But what would happen if you actually just gave glutathione? And I received a number of comments regarding this. Well, here is a published report of 2 cases with COVID-19 that were treated with glutathione. Now, you should know in the business that when you're looking at evidence, case reports are the lowest form of evidence that we have. This is not a randomized controlled trial. We have no idea whether or not the 2 patients' improvement was the result of the medications that they took. Nonetheless, it is a case report. And we can see here that there were 2 patients living in New York City with a history of Lyme and tick-borne co-infections that experienced cough and dyspnea and demonstrated radiographical findings consistent with COVID-19. these people were given 2 grams of PO or IV glutathione. Now, it doesn't say which one was given, PO or IV. And that's important from my standpoint, because when you give polypeptides orally, the expectation is that they're going to be cut up by the proteases that are in the stomach. That is the job of the stomach, is to cut up large polypeptide chains into amino acids so they can be absorbed in the intestines. So how bioavailable is PO glutathione? Some reports show that it may not be that bioavailable. But I guess the question is if you're cutting up glutathione, you're going to be cutting up into glycines, glutamates, and cysteines, which eventually are the building blocks of glutathione. The patients were also given this intravenously. What happened? Oral and IV glutathione precursors like N-acetylcysteine, like we just talked about, and alpha-lipoic acid may represent a novel treatment approach for blocking NF-kappa B and addressing cytokine storm syndrome and respiratory distress in patients with COVID-19. And the reason why they say that is because in both patients, their dyspnea improved within 1 hour of use. Now, while this is a far stretch from proving anything, it does make it very interesting to think about whether or not patients would improve if they were given both N-acetylcysteine and IV glutathione. After all, we did discuss the potent thrombolytic effect of N-acetylcysteine on arterial thrombi. These are one of the things that is given as a reason for patients having hypoxemia, and that is pulmonary arterial thrombosis. And again, the reason why we're saying this is because von Willebrand factor uses these disulfide bridges to turn these monomers into multimers, essentially polymerizing and causing the clot with lots of platelets in it. Of course, what I'm waiting for is the actual clinical trial, and we've talked about this one before. It is the study of N-acetylcysteine in patients with COVID-19. It's the only one that I can find for the treatment of severe COVID-19 infections. And in fact, they say here that this study is the first to test N-acetyl in people with severe COVID-19 infections. Apparently, it looks like it's going to be a non-randomized trial with 86 participants with a parallel assignment and an open label. In this particular trial, they're giving N-acetylcysteine at 6 grams intravenously per day.
Did we watch this
Based
one
on the
already?
case
Let me fast forward here.
glutathione would be
All right. It turns out that von Willebrand's factor needs these disulfide links. So when you want the blood to clot, the von Willebrand's factor will form these multimers in which the 2 sulfides link, like in the hair. So you get the disulfide link, and that activates the von Willebrand's factor to trigger clotting. And so what he's hypothesizing is that if you add N-acetylcysteine, the N-acetylcysteine will break the disulfide links, thereby preventing the von Willebrand's factor from clumping together in those multimers, and thus preventing clotting from occurring. And so here's this the disulfide bond reduction in bond. We don't want the disulfides. Well, you do want them if you want your blood to clot. You don't want them if you want to prevent the blood from clotting. So let me just see. They had a nice visual on this, but I can't find the video of that just yet, of the von Willebrand's factor. It's like just a
just oxidative stress, because the clots that they're pulling out of people with COVID-19, they're finding are very rich in platelets. And that means that there is also the issue of von Willebrand factor. These von Willebrand factors are connected to each other by these disulfide bonds. And as we've already talked about, N-acetylcysteine and reduced glutathione will break these disulfide bonds and cause them to lyse and potentially relieve the obstruction and the hypoxemia with COVID-19. Again, this is all a hypothesis, but it looks as though it's fitting together. And I wanted to remind.
Okay. And then let's fast forward. Those were a couple of months ago. Let's fast forward now to the latest video. So there's a video on what supplements he takes. He takes N-acetylcysteine, NAC, vitamin D, and I think vitamin C with zinc. And so zinc is important in superoxide dismutase, which helps clear superoxide in the system. And so this is a pretty interesting update. I just watched this today, although it came out earlier.
Boredom. We've got cram.com. Welcome to another MedCram.
Okay, we'll skip the first part here. Let's go right to it.
Because I found some very interesting information that I want to pass along to you. So we're going to jump right to it. And so if you're looking for a great review article on vitamin D and general human health, this is the article that you're going to want. And it also has an update about COVID-19 and some recommendations. So we've talked about vitamin D a lot. You can see some of our previous videos if you'd like to. Vitamin D is almost like a hormone. It is a lipid-soluble vitamin. It is derived from a cholesterol derivative, and it requires ultraviolet radiation to convert the cholesterol derivative into the 25-hydroxy vitamin D. From there, the body metabolizes it into 1,25-dihydroxy vitamin D into its active form, but many of these things are actually used. So back to this article, it has almost 200 references, and it hits on multiple topics, which is very germane because just last week, there was a paper published that showed a reduction in all-cause mortality associated with vitamin D levels 45 to 60. And here's that article titled Vitamin D Status and Risk of All-Cause and Cause-Specific Mortality in a Large Cohort, Results from the UK Biobank. And what were the results? After a median follow-up of about 9 years, over 10,000 deaths occurred, including 18.1% due to cardiovascular disease, 56% due to cancer. The multivariate analysis revealed nonlinear inverse associations with a decrease in mortality risk appearing to level off at 60 nanomoles per liter of 25-hydroxy vitamin D for all-cause and cardiovascular deaths, and at 45 nanomoles per liter for cancer deaths. Compared to participants with 25-hydroxy vitamin D levels below those cutoffs, those with higher concentrations had a 17% lower risk for all-cause mortality, with a hazard ratio of 0.83, a 23% lower risk for cardiovascular mortality, with a hazard ratio of 0.77, and an 11% lower risk for cancer mortality hazard rate is 0.89. So their conclusion was that higher 25-hydroxy vitamin D concentrations are non-linearly associated with lower risk of all-cause cardiovascular disease and cancer mortality. The thresholds of 45 to 60 nanomoles per liter might represent an intervention target to reduce overall risk of premature death, which needs further confirmation in large clinical trials. So what they're saying here is this is a retrospective study, a very large retrospective study, looking at a number of patients. As it turns out, over 365,000 participants over almost 10 years where they looked at these patients, and they were able to see this difference in vitamin D levels. Back to our article. If we look at this, we'll see that the article actually breaks down an introduction on vitamin D, as we've talked about. What are the causes and associated diseases of vitamin D? The physiology of vitamin D, which I'm not going to get into at this point. Its skeletal effects, and healthy serum vitamin D and 25-hydroxy vitamin D levels. And then it gets into stuff that's very interesting. For instance, the effects of vitamin D on innate immunity. And they mention here that it also exhibits direct antiviral activities against many respiratory viruses by disrupting viral envelopes and altering viability of host target cells. This process is especially robust in granulomatous inflammation, such as TB, fungal infections, sarcoidosis, and some lymphomas. They also talk about the different types of cell types, B cells, Th1, Th17, etc., and antigen-presenting cells and natural killer cells. But what I became very interested in, because of what we've been talking about, is this section on endothelial function and vascular permeability. Now take a look at this. A number of experimental studies have shown that vitamin D and its metabolites modulate endothelial function and vascular permeability via multiple genomic and extragenomic pathways. What they mean there is that vitamin D may actually directly cause something, or it may upregulate the promoter for transcription of certain genes. And they found this, that 25-hydroxyvitamin D3 and 125-dihydroxyvitamin D3 non-genomically, meaning directly, stabilize vascular endothelium, and that vitamin D3, normally circulating at about 100 times higher level than the 125-dihydroxyvitamin D3, was at least 10 times more potent than 125-dihydroxyvitamin D3 and more than 1,000 times more potent than 25-hydroxyvitamin D3 in stabilizing the endothelium. And if we're correct about our hypothesis, we need to be able to stabilize the endothelium. This may be the reason why vitamin D is associated with a lower risk of mortality in COVID-19. A lot of people have been talking about nitric oxide inhalation and whether or not this could enable and help patients with COVID-19. Well, studies have shown that 125-dihydroxyvitamin D is a transcriptional regulator of endothelial nitric oxide synthase, which causes upregulation of eNOS gene expression and increases endothelial production of nitric oxide. So here's a connection between nitric oxide and vitamin D3 levels. Furthermore, they noticed that this effect of 125-dihydroxyvitamin D3 occurred within a minute of administering the compound, implying that it wasn't being used in terms of transcriptional modification by a promoter, which would take a lot more time. There's a direct, it seems, component to the 125-dihydroxyvitamin D and the activation of nitric oxide. So what's the summation regarding endothelium? Taken together, it is evident that vitamin D and its metabolites exert pleiotropic effects on the vascular endothelium that are protective against vascular dysfunction and tissue injury as a result of local and systemic inflammation. This is exactly what we want to have in a patient with COVID-19 if our hypothesis is correct. We've been talking about vaccines and immunity and antibodies. Well, vitamin D has an effect on adaptive immunity. It has an effect on T lymphocytes. There is some question about whether or not helper T cells and memory T cells remember this infection. Well, there is an effect of vitamin D on that. There's also an effect on the B lymphocytes. And these B lymphocytes give rise to plasma cells, and it's these plasma cells that give rise to antibodies. And then this review article goes into a number of other things, including immune-related diseases like psoriasis, like type 1 diabetes, like multiple sclerosis, like inflammatory bowel diseases, like Crohn's, ulcerative colitis, etc. And it all shows very good effects. Also talks about rheumatoid arthritis and even tuberculosis. Talks about sepsis and critical illness in terms of randomized controlled trials. And then, of course, what we want to learn about, which is respiratory viral infections and, yes, COVID-19. Remember, this paper was published literally in the last day or so. So the question for those that say, well, do we actually have any randomized controlled trials that show that vitamin D works in reducing acute respiratory infections? Well, here we go. One of the proposed explanations is that the seasonal outbreak could be due to a seasonal variation in circulating levels of 25-hydroxy-D, which reaches the lowest levels in the winter. Several studies have supported this hypothesis as they reported the independent association between low-level serum 25-hydroxyvitamin D and the incidence and severity of respiratory tract infections in children and adults. A prospective cohort study in healthy adults living in New England showed a twofold reduction in the risk of developing acute respiratory tract infections in those with serum 25-hydroxyvitamin D levels of 38 nanograms per milliliter, which is 95 nanomoles per liter or more. So in this case, they weren't supplemented, but they followed those that had higher levels. And it showed that there was a twofold reduction in the risk of developing acute respiratory tract infections. COVID is an acute respiratory tract infection. Now, it wasn't there as part of those acute respiratory tract infections, but it belongs to that group of acute respiratory tract infections. And we see prospectively that a higher vitamin D level is protective from those. Children that were aged 2 years and less were 1.7 times higher likelihood of requiring hospitalization for an acute respiratory tract infection. So what is it that vitamin D is proposed to be doing? It seems as though that when respiratory viruses enter the respiratory epithelium via the specific entry receptors, whether it be ACE2 or what have you, it causes cellular and tissue damages and triggers the innate and adaptive immune systems both, which then result in airway and systemic inflammation, and in severe cases, life-threatening sepsis or acute respiratory distress syndrome. 1,25-dihydroxyvitamin D, the active form of vitamin D, not only has antiviral activities, but it also modulates inflammatory responses to viral infections by stimulating cathelicidin release, modulation of a toll-like receptor expression, and natural killer cell function, as well as suppressing overexpression of pro-inflammatory cytokines. And as we reported here at MedCram, a recent meta-analysis of 25 randomized control trials showed that supplementation of vitamin D2 or D3 can protect against the development of acute respiratory tract infections compared to placebo. They also mentioned in this paper that symptomatic infection, morbidity, and mortality observed in African Americans and obese individuals suggest the possible impact of vitamin D on the host response and susceptibility to infection, as obese and Black individuals are known to have an elevated risk for vitamin D deficiency. And they mentioned that it has been proposed that supplementation of vitamin D can reduce the risk and severity of COVID-19 infection. There's a number of references to that. Then the authors go out on a limb and suggest the following. They say, although the efficacy of vitamin D is still unclear as the results of ongoing clinical trials are still pending, it is advisable that one should maintain adequate vitamin D intake to achieve the desirable serum 25-hydroxy vitamin D level of 40 to 60 nanograms per milliliters, or 100 to 150 nanomoles per liter, in order to minimize the risk and severity of COVID-19 infection. It is well documented that worldwide, on average, approximately 40% of children and adults, 40% of children and adults have circulating 25-hydroxy vitamin D levels of less than 20 nanograms per milliliter, or 50 nanomoles per liter. And approximately 60% have less than 30 nanograms per milliliter, or 75 nanomoles per liter. Thus, patients presenting to the hospital with COVID-19 are likely to have a vitamin D deficiency or insufficiency. It is therefore reasonable to institute as a standard of care to give at least one single dose of 50,000 units of vitamin D to all COVID-19 patients as soon as possible after being hospitalized. For patients who are intubated and are being fed by a G-tube, they should be treated with a liquid form of vitamin D. Drisdol is a pediatric liquid vitamin D2 formulation that contains 8,000 international units per ml. That can be given daily to these patients to treat vitamin D deficiency. So I wanted to pass this along to you because I know a lot of you are interested in supplementation with vitamin D, and we've talked about it before. I supplement myself with vitamin D. I always recommend all of you checking this out with your doctor. It is possible to overdose on vitamin D, so it's very important that you confer with your doctor about vitamin D supplementation. We'll provide links in the description below to this paper and also the paper talking about all-cause mortality being reduced. And again, don't forget to join us at medcram.com. Thanks for joining us.
Okay, so I showed this series of videos because COVID-19 is on a lot of people's minds. So vitamin D, I'm one of those in the percentage that has a low vitamin D level. I actually had my blood checked years ago, and I've been taking vitamin D supplements for a couple of years. And I take 2,000 units per day, just what they sell at like Costco or Sam's Club, vitamin D supplement. And then I've been taking NAC as well. NAC is twofold. One use of NAC, this was in the earlier video, is as an antioxidant. And so, you know, the sulfur, the thiol was a pretty good antioxidant, so it could help clear up or react with superoxide. So NAC and superoxide can react and then lower the superoxide concentration, which should lower the endothelial cell damage. And the other benefit of NAC is that NAC can break up the von Willebrand's factor from forming the disulfide links and clumping together to form the clots. And so that's twofold. So I've been taking NAC. NAC, you know, it's a thiol, so it doesn't smell that good, but I take, there are different things. I know he takes 1,200 milligrams. Then I've been reading other people are taking 600 milligrams twice a day. I just decided I'll just take 1,000 milligrams once a day. Not quite 1,200, but that's of course that's assuming if the hypothesis is correct. You know, there could be competing hypotheses as well, or there could be different ways of explaining why, you know, blood clotting or thrombosis is such a big issue in SARS-CoV-2 or COVID-19. And so this was interesting because there's, you know, nitric oxide and vitamin D has an impact on NO, nitrogen monoxide or nitric oxide, and it's all interrelated with this redox stuff that we've been talking about. So if you're interested in this stuff, you know, he posts, and then you can get the whole story by going through. I've watched all these videos. I think he's over 100 now, yeah, or no, 98, so almost 100 videos on COVID-19. And so really pretty interesting stuff. And so, but with the supplements, what supplements is he taking? And not just him, but a lot of other doctors. I'll watch the video, like Dr. John Campbell. He's a very big proponent of vitamin D. And Dr. Mike Hansen, he takes NAC as well, I think. And so it makes sense, and there are very few side effects of doing that, you know. And I think the overdose level for vitamin D is quite high, you know. So this is why it's over the counter. You don't need a prescription for vitamin D, nor do you need a prescription for NAC, you know. And so those are two over-the-counter things that I take. All right, I hope that was informative. And what is the name of the supplement you take for vitamin D? I don't know. I just bought it, you know, Sam's Club. I just bought it off the shelf at Sam's Club. I figure, well, Sam's Club, they probably test it. But Dr. Mike Hansen, all the supplements he buys, he reads through the Consumer Journal, because the Consumer Journal, I think, they test each supplement to test the purity level of the supplements. And there are definitely good supplements and bad supplements out there, and you have to be very careful. So I'm assuming something like Sam's Club or Walmart, they probably, vet, you know, their vendors to make sure, you know, that they're selling, and so they probably have some analysis results for that, and so that's why I just got it from them. The NAC supplements, I just bought it off Amazon, and the NAC supplements, you know, there are two issues. One was the cost of the supplement. That you'll find a huge variation in the cost, and the other issue was the I should have taken the label of the bottle. I just took these are the dosages I take. So that's vitamin D, 2,000 international units. That's what I've been taking. And for the NAC and acetylcysteine, I'm taking 1 gram. You know, in the earlier studies, people were taking up to 6 grams without any adverse effects. So 1 gram shouldn't be any problem, or even 1,200 milligrams shouldn't be a problem. And I take this as a prophylactic, and it's been proven. NAC has been proven as an excellent prophylactic for influenza. You know, people who are taking NAC didn't suffer nearly as severe complications with influenza as those not taking NAC, and that was through a journal, And so, yeah, so I think I think this is really relevant right now. And I myself am taking it, and you know, his hypothesis seems to make sense, you know, to explain the observations of heavy blood clotting. In fact, there's one more video here that I'd like to show, showing recent autopsies of COVID-19. Let's see if it's here. Recent autopsies, yeah, here. Ivermectin is interesting as well. Ivermectin was from the other, you know, ivermectin, but ivermectin is not something you can get over the counter, but people are thinking about taking that as well. That's the other hypothesis of blood clotting. Both hypotheses might be in play. The other hypothesis is that SARS-CoV-2 links platelets together, causing them to clot. And I showed that was in the earlier video show. But
so sexy you couldn't tell
it seems to make sense because you know, there's ACE2 receptors in lots of different organs, and they're seeing clots in lots of different organs. And the clots are, you know, there's something called embolisms. You know, embolism is when a clot travels, you know, and then clog somewhere else. So like one thing is deep vein thrombosis. People get blood clots in their legs. This is from sitting around, like on long haul flights and stuff, where the blood kind of pools and then starts to clot, you know. And so I've had it too, deep vein thrombosis. You get a blood clot in your leg, and that blood clot breaks up. That blood clot breaks up and then starts traveling. So I had a deep vein thrombosis that traveled into my lungs. I got clots in my lungs. So clotting is something that, you know, factor 8 and other things to keep track of. Clotting is a big issue. In surgery, you know, in surgery they get blood thinners. This recent video here was a little bit, I don't know, a little bit, there's some evidence, you know, they're saying that there are some people who are given blood thinners. Blood thinners help prevent clotting, you know, and they're on full dose of blood thinners, and yet they are still having clots, and they still died from clots. And so that's kind of frightening as well, because in the earlier paper, in one of the earlier videos, he was saying that, or one of the papers was reporting good results from giving blood thinners or anticoagulants to patients, COVID-19 patients, and showing improved results for oxygen, you know, uptake. So that was promising. But then on this more recent data here, they're showing that some of these patients that passed away and that underwent autopsy were on full dose, but one of the hypotheses is it was given too late, you know, too late. They needed to be on blood thinners and anticoagulants immediately. And that's why they suffered from so many clots. And these clots are everywhere, and they're saying, you know, they're in lots of different organs, and they aren't they might be traveling as an embolism, but it looks like they're being generated at the site.
Welcome to another mid-cram COVID-19 update. I want to let everyone know that I took a little bit of a break last week. I'm feeling just fine, and I do appreciate everybody's concerns. We've got a couple of papers I wanted to analyze, and we'll jump right into those right away. Let's quickly take a look here around the world. Daily cases in the United States continue to climb. Daily deaths are now starting to climb in the United States. Interesting, in California, the daily cases have kind of plateaued. Daily deaths in California are on the increase. In Florida, there's been an increase in daily new cases, and that is accompanied by an increase in daily deaths. In Texas, there is an increase in daily new cases, and this is accompanied by an increase, more than doubling of the daily deaths in Texas. We've been watching Australia, but it's winter down there, and we can see that there is an increase in the daily new cases. Currently, the deaths in Australia are negligible. India here, definitely an uptick in daily new cases that has been very consistent here over the last number of weeks. And we've seen a consistent increase in the daily deaths as well. I want to show you what we're working with here locally, where I work in San Bernardino County on a regular basis. And you can see here we've got what's going on in the intensive care units across the county of San Bernardino, which is in Southern California. And here we have April 1st, May 1st, June 1st, and we're ending up here with July. I think this last one here is July 8th. That's the one that we have data for. And we can see here what's going on in the intensive care unit. In terms of ICU census, these purple lines represent the available empty ICU beds. You can see here that in the beginning of April, we increased our capacity county-wide to take care of patients. You can see if we hadn't done that, we would be in dire straits at this point. The green, which is by far the largest proportion of ICU beds here, are actually other non-COVID ICU patients. And you can see that that sort of started to come up once the opening up of Southern California came to fruition. Here, the red going across are actual COVID patients. And this yellow, as we go across here, are suspected COVID patients. You can see with the improvement in testing that has occurred over time, that proportion has dropped dramatically. And we're now able to see exactly which patients are suspected and which ones are not suspected. But clearly you can see that the number of ICU patients has gone up since June pretty significantly, almost a doubling of the number of ICU COVID patients. And overall, this represents maybe either a quarter to a third of the number of ICU patients total in the entire county. You might think that that's not a big deal, but if, because of COVID, and when COVID spreads, it spreads exponentially, it's not going to take very much time to double. If you were to double the amount of patients in the intensive care unit, that would completely use up all of the surplus ICU beds that are available. And at that point, all patients requiring ICU care, not just COVID patients, but even those patients here that are non-COVID patients would feel the squeeze in terms of ICU beds. And so if you had a heart attack, or if you had a pulmonary embolism, or if you had post-operative sepsis, it would be very difficult to find intensive care services, even though you don't have COVID-19. So this is just one snapshot here of one county in one state of the United States, which is just one country. This is being multiplied in many, many different counties and states and countries around the world. One of the questions might be, how did you go from here, available ICU beds, to up to here? As the amount of patients requiring ICU care jumped, we have to be very creative. So what are we doing in these situations? Well, in these situations, the county and the state specifically is allowing us to license ICU beds where we would not be normally licensing ICU beds in the hospital. And where would that be? That would be in regular patient rooms, for instance, in rooms that would not be ICU. We could also be doing this in what we call the PACU. These are where patients come out of surgery and are staying and they're being monitored there. We could turn those into ICU beds. Of course, it's not ideal. Sometimes the monitoring is not as good as it would normally be. But as we've said many, many times here, the good is not the enemy of the perfect. I want to talk about this paper because we've talked extensively in the past about the pathophysiology of COVID-19. Don't want to take time to go through a lot of that at this point, but remember that the concern is that the virus attacks the ACE2 receptor, which causes oxidative stress, which causes inflammation of the endothelium, releasing procoagulant substances, and that leads to thrombosis. Well, here is a study out of New York University looking at 7 autopsies of patients and characterizing what they found. And what they found was not just clots in the lungs, which is what we've been looking at before. There was that paper, remember, in the New England Journal of Medicine that looked at microthrombi in the lungs. But here we're seeing megakaryocytes. So what is a megakaryocyte? Megakaryocytes are the precursors to platelets. These are large cells, mega meaning large, that have multiple aggregations, if you will, of small platelets coming into one cell. This is how they are made. And we're seeing a lot of these, as well as platelet and fibrin thrombi, not just in the lungs, but on these autopsy series in just about every other organ in the body. And the question is are they forming there, or are they embolizing or traveling to those areas after they've been made? So let's take a look at this article that was published in The Lancet, specifically eClinical Medicine. They say here that there's an increasing recognition of a pro-thrombotic state in COVID-19, and post-mortem examination can provide important mechanistic insights. So what they did was they looked at COVID-19 autopsy series in 7 patients and looked at the lungs, heart, kidneys, liver, and bone at a New York academic medical center. This was NYU. So they found 7 patients, and about half of them were male, half female. And they looked at them regardless of anticoagulation status. So some of these patients were on anticoagulants, some of them were not. Some of them were on full dose anticoagulation, as we would call it. Some of them were just on prophylactic or preventive dose type of anticoagulants. And notice here that all of the autopsies demonstrated platelet-rich thrombi in the pulmonary, that's the lungs, hepatic, that's the liver, renal, kidney, and cardiac microvasculature. And that megakaryocytes, those are those cells that give rise to platelets, were seen in higher than usual numbers in the lungs and in the heart. And in 2 cases had thrombi in the large pulmonary arteries, where casts conformed to the anatomic location. So in other words, it completely filled up the tubes. Let's go on and take a look here in their interpretation. They say in this series of 7 COVID-19 autopsies, thrombosis was a prominent feature in multiple organs, and in some cases, despite full anticoagulation and regardless of timing of the disease course, suggesting that thrombosis plays a role very early in the disease process. The finding of megakaryocytes and platelet-rich thrombi in the lungs, heart, and kidney suggest a role in thrombosis. Here we can see different tissues of the human body. Here in panel A, this is the medium-sized blood vessel in the lung. And we can see a coagulation here by the yellow star. In B, for those who are not inclined to know this, this is the kidney. As you can see here, some tubules, and you can see that there are, at the arrows here, thrombi in the kidneys. Here in C, this is what the heart looks like under section. You can see the sarcomeres and the muscles, fibers going across. And here, at the blue arrow, we see another thrombus occurring. And then over here is lung tissue and microvasculature. We can see multiple blood clots here in the microvasculature. Here's some more images from the study. This is the hilum of the lung, and this is the pulmonary artery. These are clots that are sitting in the pulmonary artery, preventing the blood from flowing, and that they're quite easily removed. You can see here in section B. Here in another case, some more blood clots here. And when we section this, we can see that the alveoli here, instead of being nice and thin, allowing the oxygen to diffuse into the blood, has something called diffuse alveolar damage, or DAD. And you can see here in this artery that it is completely filled up with microthrombi, right where the yellow star is. Here's another look at some more cases. This is the heart. Here we have a microthrombi with fibrin and thrombin, but in the middle of it, you can see a megakaryocyte. This megakaryocyte will eventually break up into multiple platelets, but it's very interesting to see a megakaryocyte in this position, not normally seen. Here we see in slide B, this is a cross-section of lung. Again, very thickened alveolar walls, not very conducive to transmitting oxygen. And what we see in all of these capillaries is where all these black arrows are megakaryocytes. These are things that come from the bone marrow that normally break up into forming little platelets. Here, those of you who can recognize this, this is kidney. You see a lot of microtubules and things of that nature, and a glomerulus. That's the big thing right here. What do we see in the middle of the glomerulus? Again, we see something get lodged in there called a megakaryocyte. Why is that there? When we look at the bone marrow where the megakaryocytes are actually coming from, you can see some fat. Those are those round empty spaces because they get dissolved when this thing gets processed. But what we're staining for here is something called CD61, which we see on megakaryocytes. And you can see that it is very rich in these megakaryocytes. Here's some more slides related mostly to the heart. The red is muscular tissue. This is from the heart. But you can see, generally speaking, a kind of a blackish haze here. That is because what you're seeing there are the nuclei of white blood cells. Yes, there's diffuse inflammation here, or myocarditis. And that's what we're seeing here is a bunch of white cells that are infiltrating here, and that's what's causing inflammation. We see it again over here in the epicardium. That's the outermost layer of the heart. And you can see that blue haze all through here. Those are all white blood cells that have gotten in there. If we look at the microvasculature of the heart, these little red dots that are pointed out by yellow arrows, again, megakaryocytes. That's because we're staining for CD61 there. Why are they there? That's a good question. Here we see a cross-section of the ventricle of the heart, and you can see is some pallor of the ventricle, and that may be related to less blood supply from ischemia. Here we see a cutting open of the heart, and we can see in the trabecula carne, which is basically another way of saying just in the area here that tethers the mitral valve down and it's sort of at the apex of the heart. We can see some clots, also some clots over here in this area. This is fibrin clotting. Here's another slide looking at this. Here's the EKG on admission of another patient and the EKG a little bit later. Let's zoom in on those so we can see that a little bit better. For those who don't know this, 2, 3 in AVF, look at the inferior aspect of the heart. We're definitely seeing ST segment elevation above the baseline. And also in V5, V6, and even V4, we can see that the ST segment is well above the baseline, indicating that this patient is having an ST segment elevation MI. And furthermore, what the authors are trying to show here is a bit of hemorrhage at the junction of the left and right ventricle that may have caused some of those findings on the EKG. Here again, we see another megakaryocyte in the strands of the fibers here of the heart. We see here at E, F, and G, thrombus, thrombus, and thrombus. All of those could be the reason for the myocardial infarction or the heart attack. So what is their discussion of this? Let's look at the first paragraph. They say, in these series of 7 autopsies in patients who succumbed to COVID-19, there are several unifying themes observed in the histopathology. Thrombosis is a prominent feature in multiple organs. And in some cases, this is despite full anticoagulation. And this really goes along with what I've seen clinically in the patients that I have been taking care of. Despite them being on full dose anticoagulation, we're still seeing complications of them having clots. And what kind of clots are they? They go on to say platelet-rich thrombi were present in the pulmonic, hepatic, renal, and cardiac microvasculature. Based on the anatomic cast pattern in the thrombi, many of the thrombi appear to have formed in situ. That means right there in place. In other words, they didn't form elsewhere and travel to that place. They formed right there in that place. They also say that it was ante-mortem. What does that mean? That means there before they died. How do we know that? It's because of these lines of Zahn. Lines of Zahn, as we showed you before, are these layers that form and show that the blood clots formed while blood was pumping, while there was fast flowing blood. And so obviously that's going to happen before somebody dies, not clotting after they die. However, they say here that embolism with further local propagation cannot be excluded based on the lack of deep vein dissection. In other words, they didn't look at the deep veins in the autopsy to see if there was blood clots in those lower areas. They go on to say that the extensive nature of platelet fibrin thrombi in the alveolar capillaries in our patients may explain the observation that oxygenation is disrupted in an exaggerated fashion early in the disease course of patients with COVID-19. As this suggests evidence of ventilation perfusion mismatch unrelated to hyaline membrane formation. What are they saying here? They're saying that, yeah, the alveolar membrane thickens, but that's probably not the problem and the cause of why we're getting oxygenation issues. They're thinking that maybe the oxygenation issues are related to these platelet fibrin thrombi. And that's what we've been saying now for a long time. They also go on to mention the interesting finding of megakaryocytes, both in the thrombi themselves, but also significantly elevated in the bone marrow. Now, here's the interesting paragraph. What they say here is that the thrombi that they saw were located in the veins and in the pulmonary arteries and the pulmonary arterioles and in the microvessels, but not in systemic arteries. What they mean to say here is not in the arteries coming from the left ventricle that supply the organs. Watch what else they say. Despite elevated fibrin degradation products, in only one case of a patient with cirrhosis did we observe glomerular thrombotic microangiopathy. Why is this interesting? This would seem to go against the possibility that this is DIC, or disseminated intravascular coagulation, hemolytic uremic syndrome or thrombotic thrombocytopenic purpura as the predominant pathophysiological pathway. Now that's important for those that understand these things, because these things are one of the leading suspicious characters or processes that could be causing this. Schistocytes are simply just broken up red blood cells. As the red blood cells are careening through these vessels, when there are little strands of fibrin, they get sheared on these and they get destroyed. Instead of seeing nice round red blood cells, you see fragments of red blood cells, and those are known as schistocytes. Well, those are typically seen when you have endothelial damage. They didn't see any of those. They found no endothelial abnormalities. Now that would seem to fly in the face of what we've been saying, which is that endothelial damage because of the SARS-CoV-2 virus binding the ACE2 receptor causes oxidative stress, endothelial damage, and then thrombosis. But notice what they say here. But we cannot rule out increased exposure of tissue factor, erosion of the endothelial glycocalyx, or other mechanisms of endothelial dysfunction that could be procoagulant without showing histopathologic evidence of cell activation or erosion. A recent autopsy series of COVID-19 cases incorporated endothelial electron microscopy demonstrated ultrastructural endothelial damage and increased angiogenesis as compared to cases of fatal influenza with differential regulation of genes related to angiogenesis and inflammation. They go on to talk about troponins and elevated troponins in patients with COVID-19 and why might that be? And one of the theories is that there might be viral myocarditis, but they said that this is actually a pretty rare occurrence. And in fact, a previous COVID-19 patient that did have viral myocarditis was actually infected with influenza at the time, so it's hard to say. They conclude that tissue-proven viral myocarditis appears to be a relatively rare occurrence in COVID-19. They feel that based on their data, thrombosis of the microvasculature and the cardiac veins appears to be a common cause of elevated troponin in COVID-19. If you had thrombosis of the cardiac veins, that would mean that the blood would not be able to drain back into the venous system, and that would cause a pressure load and therefore inability to get oxygen to the cardiac muscle, which would cause an elevation of troponin. In fact, the occurrence of thrombosis in COVID-19 apparently is so common in these series of COVID-19 autopsies that they were able to demonstrate for the first time in one of their autopsies that there was a thrombosis of a cardiac vein, not a cardiac artery, but a cardiac vein, and that this could cause acute myocardial infarction in the absence of obstructive coronary atherosclerosis. In other words, it's very possible that you may have a patient with COVID-19, they have an MI, and you send them to the cath lab afterwards, and you do the cath lab, you do an angiography, and their arteries are beautiful. There's no thrombosis anywhere. Well, it could very well be that the thrombosis is not in the coronary arteries, but in fact in the coronary vein. In one of their cases here, in case number 3, they had a thrombosis of an intramyocardial vein corresponding exactly to the infarction zone. In terms of the kidney, there was virons that were actually observed in the proximal tubular cells. And of course, a number of acute tubular necrosis at various different levels were seen in a number of patients in previous studies. So all in all, a very interesting study. Of course, we'll put the link to it in the description below. But I want to take this with these findings in mind and show you a second study, which I think will be very useful practically for those of us taking care of patients in the hospital. And that's this paper titled Prognostic Factors Associated with Mortality Risk and Disease Progression in 639 Critically Ill Patients with COVID-19 in Europe. Initial report of the International Risk-19 ICU Prospective Observational Cohort. And this paper was published out of Zurich, Switzerland. So what they did here was they took 639 critically ill patients, looked at a number of variables, and they tried to determine which things were going to determine likelihood of survival versus non-survival. And what they came up with was that the patient's creatinine, D-dimer, lactate, potassium, PF ratio, AA gradient, and ischemic heart disease, all of those were independently associated with ICU mortality. So let's take a look at those findings. And as you can see here, they graphed it out, looking at day 0 all the way to day 7 in most of these cases. And here you can see on the y-axis things like leukocytes, the neutrophil divided by the leukocyte ratio, thrombocytes, things like the D-dimer level, interleukin-6, plotted over time. So the non-survivors are in red and the survivors are in blue. And they did a bunch of statistical analysis to see which ones could be seen as independently determining whether or not the patient was going to survive or not survive. So let's take a look at those. Here they are. So again, we have overall survival in days. And these are Kaplan-Meier survival curves, by the way. So you can see here that we start off at 1.00, and the red and the blue here are different. They've determined what the variable is. So for instance, this one is the creatinine, and it's measured in micromolar per liter. But if we want to convert that into what we would see normally in the United States, then we would say that a creatinine of less than 100 or greater than or equal to 100 would be around 1.14. So that would be the cutoff. If you wanted to make this practical, you could just say 1.1. So if patients had a creatinine of greater than 1.1, then they would be in this red line, versus those having a creatinine of less than 1.1, which would be here in this blue line, having a slightly higher but statistically significant survival rate. And you can see here that the hazard ratio is 2.09. Well, let's take a look at some of the other ones here. Here we have D-dimer. If it was less than 1560, then you would be in the blue, higher chance of survival. Greater than 1560, lower chance of survival. These are all basically on admission. Here we have, do you have ischemic heart disease or do you not have ischemic heart disease? Clearly here, if you said no, better chance of survival. If you said yes, worse chance of survival. Let's take a look over here at the lactate. If you were less than 1.55, better chance of survival on admission here versus greater than 1.55, less chance of survival. What about the potassium? If the potassium was less than 4.16, better chance of survival versus greater than 4.16. And finally, the PF ratio. And for those who don't remember what the PF ratio is, it's simply the PaO2 on the blood gas divided by the amount of oxygen that the patient is on. So for instance, if the PaO2 is 80 and the patient is on 50% FiO2, then it would be 80 divided by 0.5, which would be 160. And we would just look at this here. And of course, if it was less than 206, less chance of survival. Greater than 206 on admission, higher chance of survival. So if you look at these, there's a case to be made in each one of these situations of microthrombi. If there is microthrombi in the kidney, that's going to make the creatinine worse. Obviously, if the microthrombi is potentially worse, we're going to have a higher D-dimer level. If we've got microthrombi, somebody with ischemic heart disease is not going to tolerate that as well. Here again with a lactate, if we have microthrombi, potentially we're not going to have perfusion and oxygenation. If we have no oxygenation or less oxygenation, that means we're going to have anaerobic metabolism, and the product of anaerobic metabolism is lactate. Again, potassium may be just simply a surrogate here of the ability of the kidney to process potassium. If it's not processing it well, you're going to have higher potassium rates. And then finally, the PF ratio is pretty self-explanatory. If you have microthrombi in the lungs, your PF ratios are going to be very low. So you can see here that in each one of these situations, it could independently lead to a worse survival based on thrombosis alone. But I believe the one that is closest and a direct measurement of microthrombi is, in fact, the D-dimer. And if you'll notice, the hazard ratio out of all of these is the highest in the D-dimer. So I think that is probably the most important. You can also see that it has the biggest difference between survival and non-survival in any of these independently linked hazard ratios. So I thought this was an excellent article. I believe that it is casting light onto what is really going on here in COVID-19 in terms of the pathophysiology. I believe based on what we're seeing here, that thrombosis, particularly with platelets and fibrin and megakaryocytes, is what is leading us to the hypoxic mechanisms with COVID-19. I believe it is happening very early in the course, probably before the patients even get to the hospital. I also believe it's probably the reason why we're seeing a very wide range of symptomatology in patients, because it really just depends on where the thrombosis occurs. If the thrombosis is occurring in the brain, you're going to get neurological symptoms. If the thrombosis is occurring in the lung, you're going to get shortness of breath symptoms. If the thrombosis is occurring in the kidney, you're going to get renal issues. And I think more deliberate research really needs to go into how do we prevent these catastrophic microthrombi from occurring. And for those healthcare providers that are interested, we have a course at medcram.com with 545 reviews with a 4.9 out of 5-star rating that you can review here at medcram.com and to sharpen your skills in terms of EKG interpretation. Thanks for joining us.
Okay, that's that for COVID-19. We got to get back to our chemical reactions here. So switch gears and let's take a look at reactions here. That's chapter 10. All right, so we covered redox reactions. Redox chemistry is very rich and also potentially very violent, in terms of energy. It need not be that way. Your bodies are undergoing redox reactions in a controlled fashion all the time. There are other types of reactions as well, metathesis and acid-base. So we're going to take a little time and look at metathesis and acid-base before we move on to chapter 10. And so I posted some slides here for metathesis and acid-base. And it's going to be more chapter 8, 9 additional handouts. And so this was the original one for the PowerPoint here. This just talked about the redox. Let's go to chemical properties, part 1 here. This is a handout I use in Chem 1A. Actually, I've used Chem 4, Chem 1A, Chem 1B, just the same handout for those classes. And so this is kind of just going through introduction, chemistry, properties, chemical properties versus physical properties. I had talked about this earlier, first day. Of course, we want to correlate composition, structure, and properties, both physical and chemical. And that's what we do as chemists here. This interrelationship between composition and structure, to understand how composition, structure, and properties are interrelated, we use a mix of theory and descriptive chemistry. Sometimes it's kind of difficult to do it entirely theoretical, And so theory versus descriptive chemistry. Theory, we could sort of, is HCl a gas, liquid, or solid at room temperature? How would you do that theoretically? You could do that theoretically by looking at the molecules and modeling those and using kinetic molecular theory, but that's a lot of work. It's easier just to know HCl is a gas. So most people have it memorized. Pure HCl is a gas. It's colorless, a clear colorless gas. And so that's a descriptive chemistry or memorization versus theoretical, what is HI? Is HI a gas, liquid, solid? What color is it? Oftentimes it's too much work to do that theoretically. It's much more easier just to look it up or memorize it, we use properties all the time to ID things. So this is going back. I'm going to skip these because this is going back to.
Hey, Professor?
Yes.
Is it break time?
Is it break time? Okay. All right. It's break time. Yeah, I guess I missed that. And so we'll go on break. Let's take another 15-minute break, and then we'll start again after break. Okay. Let me stop the recording. Hopefully I recorded this. Let me see. Yeah. Just pause. Yeah. But okay, we're going to leave the COVID-19 stuff and go back to our reactions. I want to finish this here before moving on. And so this is just property stuff. As far as chemical properties go, there are different classification schemes, and this is the typical classification scheme. You know, what types of chemical properties, what types of chemical reactions there are. And so a lot of books break it up. Like our book, we have combination, decomposition, acid-base, single replacement, double replacement, combustion, precipitation, et cetera, et cetera. But this is not a comprehensive list. That's one of the problems. And then there's overlap. You know, for example, we'll have combination reactions that are redox, and we'll have combination reactions that are metathesis, and combination reactions that are acid-base. And so just because it's a combination reaction doesn't give you a whole lot of insight into it. It's just a pattern. These are just simple patterns that people look for. And so here are some problems. It's not comprehensive. So where would you put this? You know, HCl plus HNO3 plus gold, you know, what kind of reaction is that? Is that a, you know, what type? And this reaction is an interesting one. Gold, I said, is a noble metal, so gold is very hard to react, but this will actually react with gold. This combination is called aqua regia. Aqua regia. Aqua regia is royal water, and aqua regia can dissolve gold metal. Here. Sometimes it's confusing, like for example, this is a combination reaction, A plus B yields C. This is also a combination reaction where you have compound A plus compound B yields compound C in this case. But you know, the mechanism for this, you know, the driving force for these reactions are totally different though. So it's a bit confusing. That's why I call it element plus element. Element plus element combination reaction is a redox reaction. We looked at these. And so you could form different oxides of carbon, just like we did for nitrogen. This bottom one happens to be an acid-base type reaction here. So the scheme I'm using is an alternative classification scheme. I have three basic types of reactions. And these three basic types of reactions are based on the driving force, you know, what drives the reaction for. Like, for example, in oxidation reduction or redox reactions, we want to go from stronger oxidizer, stronger reducer, to weaker oxidizer, weaker reducer. And that would constitute the driving force for redox. It's always the same for a redox reaction. However, for these, it's different, you know, different driving forces. So we're going to look at metathesis and acid base. It doesn't matter what order we go in. So I started off with redox this semester. And now let's look at metathesis and acid base. And so what is the driving force? You know, driving force is simply, as far as theory goes, is the formation of a more thermodynamically is energetically more stable product from less stable, higher energy reactants, you know. And so what clues do you get that you're forming something more stable? And so in terms of descriptors, like weaker oxidizer is more stable, less reactive than stronger oxidizer. So when we're going from stronger oxidizer to weaker oxidizer, that would be a clue that we're going from something that's less stable thermodynamically to something that's more stable thermodynamically. And that's for redox reactions. In redox reactions, we expect that. And so let me give you a quick example of a redox reaction here. This is a redox reaction in which we'll take two waters, two H2O liquids, and then we're going to form two hydrogen gas plus an oxygen gas. And so would you expect water to decompose into hydrogen gas and oxygen gas? The answer is no, because when we look, hydrogen would be the reducer going backwards, and oxygen would be the oxidizer going backwards. And the two waters, one water acts as the reducer, the other acts as the oxidizer. So when we compare water, you know, what's a better reducer, water or hydrogen? Which one's easier to burn, hydrogen gas or water? Hydrogen gas is. What's a better oxidizer? You know, we need an oxidizer to burn wood. And so if you're going to burn wood, are you going to use oxygen as the oxidizer to burn wood, or are you going to use water to try to burn wood as the oxidizer? And here, there's no driving force here because we're going from weaker reducer, weaker oxidizer to stronger. The reverse reaction here is favorable. The reverse reaction would be very favorable because we're going from stronger to weaker. And so in this case, there's no driving force forward, there's a driving force reverse. And so that's what we're looking for. What are some other clues? Well, if we're not dealing with redox, some other clues are like precipitation. I'll just abbreviate PPTION, precipitation, gas formation or effervescence. Formation of going from a stronger acid to a weaker acid. Stronger acids more reactive, less stable. Weaker acids more stable. And going from a stronger base to a weaker base. And those would be other types of things we'd look for descriptively in driving forces. So what we want to do is understand chemical properties in the context of redox, acid base, and metathesis, these three reaction types. And we want to classify all chemical reactions that we encounter into one of these categories. Sometimes there's a little overlap between acid base and metathesis. And we want to be able to predict the potential reactions and their products, between substances here. And so the classifications go like this. For example, when we're looking at redox, there are a whole bunch of subcategories here, like single replacement, which talked about the chart method here, skeleton. These are the basic types of redox reactions that we encounter. Combustion. Combustion I forgot to include here, but combustion's important. Combustion of hydrocarbons and carbon, hydrogen, oxygen compounds to yield CO2 and water. That's complete combustion. And so combustion reactions, that falls into the redox scheme. Then we have metathesis. Metathesis are ion combinations. That's the simplest. We're just combining ions. What ions like each other? Which ones want to react? One type of pattern that we see is double replacement. Single replacement is a pattern in redox. Double replacement is a pattern in metathesis. Then we have acid-base reactions. There are three types: Arrhenius, Bronsted, Lowry, and Lewis. We're going to spend practically all our time looking at this one, Bronsted, Lowry, and a little bit on Lewis. Arrhenius, not much at all. The Lewis are the most comprehensive. But also difficult, more difficult than Bronsted, Lowry. So, continue here. When we predict reactions, we make certain basic assumptions. These are what are called standard thermodynamic conditions, concentrations of 1 molar. A molar, this is what the capital M here. A molar is if you have a mole of whatever dissolved in a liter of total mixture. That's molarity or molar. And it's defined as, the moles of what we call solute. Solute is what you dissolve over a liter of solution. Solution is the total mixture, and solute is one of the components of the solution. So that's molarity, moles per liter. And gases at 1 atmosphere or 1 bar. I should say 1 bar here. I said about because, as long as we're close, then our basic assumption should be all right. Let's look at a reaction here. This is an example of what we call a double replacement reaction, HCl plus AgNO3. It has a pattern to it. It's an AB plus CD pattern. AB plus CD yields CB in this case and AD. That's what we have here. So we expect a reaction for this under normal conditions, but if the conditions are very dilute, very dilute, we might not see anything. There could be no reaction, even though we have HCl and silver nitrate present. If the concentrations are very low, we might not detect any reaction at all, because there might not be any reaction at very low concentrations. Here, under normal conditions, silver chloride and nitric acid, we expect no reaction. But if we use hot concentrated nitric acid, then we get reaction occur. Here's another double replacement reaction with lead-2 nitrate and sodium hydroxide to form lead-2 hydroxide and sodium nitrate. But if we add too much hydroxide, what happens is we form this species here. This species is called trihydroxide plumbate 2 ion. And what happens is if we add too much hydroxide, we don't get this white solid appear. This we call a white PPT. It disappears. So white PPT would disappear back into solution. Okay, that's one. The other assumption is we're looking at the thermodynamic driving force. Thermodynamic driving force tells us which is lower in energy. So for example, diamond versus graphite. Graphite is lower in energy thermodynamically, so graphite's more stable. And so what that means is there's a driving force for the diamonds to decompose into graphite, because graphite's low in energy. And so I say here, graphite is more thermodynamically stable, but the kinetics of this change dictate that diamond is metastable and does not readily decompose. And so what has to happen in order to go from diamond to graphite is all the bonds have to break and be rearranged. That's very difficult to do. Even though this is more stable, the cost is too great. And so it doesn't happen. And so diamonds are metastable. But what it means is you don't have to worry about the stability of diamonds. Diamonds will last forever, basically. Because this transition from diamond to graphite is so difficult mechanistically. And so diamonds do not readily decompose. All right, so let's take a look at metathesis reactions. With metathesis reactions, these are typically reactions of 2 or more ionic compounds or ions. More specifically, we can just look at ions and find favorable ion combinations. What ions like each other? In order to determine which ions like each other, we look for clues, for this. The theory is we want to form more stable thermodynamic products, and it has to do with bonding. Bonding and bonds, the formation of bonds is going to be dictated by quantum mechanics. Quantum mechanics is theory that underlies chemistry, but looking at this quantum mechanically is a lot of work, and so we just look for little clues, that this might be more stable. And one of the clues is precipitates. When you form a precipitate, you're forming like an insoluble solid. The ions would come together and clump, and they stay clumped together and precipitate out of solution. And so precipitates are formation of stable solids. Gas formers, gases are often more stable in certain respects. There's other factors with gases, which we'll talk about later. And then stronger acid to weaker acid. Likewise, if we have stronger acid to weaker acid, we also have stronger base to weaker base. That holds true. And so it doesn't always have to be ions. Sometimes we have weak electrolytes, that could participate, like ammonia and ammonia-like compounds. Ammonia-like compounds are called the amines. And so ammonia and the amines are weak electrolytes. Now, what are weak electrolytes? Weak electrolytes partially dissociate in water. Now, ammonia, what the bases do is something called hydrolysis. And so let's look at base hydrolysis. Lysis means to break apart. And so hydro is water. And so we're going to break apart water. And so in other words, the ammonia and the water react with one another. In this process, the ammonia, which is a base, bases like hydrogens, takes a hydrogen from water to form ammonium and hydroxide. And so what happens in ammonia is a little bit of ammonia reacts with water to form some ions. And these ions can react in metathesis, even though there's a small amount. This small amount of ions, this is favorable in the reverse direction. That is, the driving force is backwards here. Now, the driving force for this is going from a stronger acid to weaker acid, and a stronger base to a weaker base. So what's a stronger base? Let's say base, ammonia or hydroxide. It turns out hydroxide is a much stronger base than ammonia. And what's a stronger acid, water or ammonium? It turns out ammonium is a much stronger acid than water. And so the driving force is actually reversed. But even though the driving force is actually reversed, there's going to be violent collisions, due to kinetic molecular theory during the molecule motion. And so a little bit of this forms, a little forms. Well, how much is a little? A little is less than 0.01%. So you take 100% of this, call this 100%, and then only 0.01% of it reacts, which is minimal. But a little forms, which might be enough for metathesis reaction, which might be enough for metathesis. So even though we might have a molecular compound like ammonia, what ions does ammonia constitute? Now, I know I've written ammonia like this many times, with the H pluses like this and N3 minus, but this is to do oxidation states. These aren't the actual ions. Ammonia doesn't consist of ions like this. We use the oxidation state to look at its redox property. Having a 3 minus here means it's electron rich. But actually ammonia is just a molecule. It's going to be a nitrogen with 3 hydrogens bonded to it, something like this, 2 dots there. So some weak electrolytes could potentially participate in metathesis reactions, which involve ions. It's favorable ion combinations. At low levels. So if we want to see if we're going to form a precipitate, precipitates are usually solid that come out of solution. So if you have a solid precipitating, it's usually an indication of stability. And so what we want to do is we want to review the solubility rules for ionic compounds. Like group 1 ammonium salts are all soluble. Acetates, chlorates, and nitrates are all soluble, et cetera, et cetera. And so we went through these already, the solubility rules. The thing is, though, we went through it once in class, but how many times have you reviewed the solubility rules since we covered it? Have you reviewed it to the point where you have it memorized? It's typical that in Chem 4, you're supposed to memorize the solubility rules. One of the things that helps in memorizing solubility rules is if you could see a pattern. The people who can see the pattern are the people who've looked at it, usually the people who've looked at it longer, longer. The more times you look at it, the more you'll think about it in different ways. And so, do you notice anything about the solubility rules? Any patterns? I assume you've read through it at least once. I don't remember when I wrote down the solubility rules. Does anybody remember when we covered those? It should be in your notes, and you probably should have seen it. More than once. Well, one of the patterns that we saw, that's for molecular compounds. This would be for ionic compounds. But yeah, group 1 soluble, exactly. That's it. That's the one. And some of the patterns we see is the higher the charged species, the less soluble, the more insoluble. Insoluble species are going to result in precipitates occurring. And so that's it. We'll take a look at some species right now. For example, let's look at should we look at? Let's look at. I'm going to look at two chemicals: sodium hydroxide. You know what sodium hydroxide is used as? One of these uses is drain cleaner, and then we have magnesium hydroxide. You know what magnesium hydroxide is used as? Milk of magnesia is used as like an antacid. But both of these are hydroxides. This is sodium hydroxide, that's magnesium hydroxide. So you know, it's a hydroxide, so you expect it to have certain properties associated with hydroxides. And one of them is reacting with acids or neutralizing acids. These are bases. Let's say you needed some milk of magnesia, you know, stomach acid or something like that. And so you needed some milk of magnesia, and you go to your medicine drawer and you're all out. But you remember you have a container of, you know, Red Devil Lye is the brand I saw, Ralph's, I think it was. Red Devil Lye drain cleaner. And then you recall that Red Devil Lye drain cleaner contains sodium hydroxide. And this is magnesium hydroxide. And so can you eat the sodium hydroxide instead of the magnesium hydroxide? Use that as antacid? Would you substitute drain cleaner for milk of magnesia? No. You wouldn't, because what were the solubility rules for the hydroxide? And so the way to memorize them is the repetition, you know. But if you go back and look, when we covered this, I completed the table from earlier. I forgot what day, but hydroxides are insoluble, except group 1, ammonium, and calcium, strontium, and barium. Calcium, strontium, and barium. Calcium, strontium, barium. So this is a group 1 hydroxide. So this is soluble. However, this is magnesium, and magnesium is not one of the exceptions. Group 1, ammonium, calcium, strontium, barium. So magnesium hydroxide is insoluble. It's insoluble. Sodium hydroxide is what we call a strong base. Magnesium hydroxide is a weak base. This is strong. And what makes magnesium hydroxide weak is because of its insolubility. You know, when you drink milk of magnesia, it's a paste. It's a really pasty, powdery liquid because there's a whole bunch of dry magnesium hydroxide suspended in a mixture of liquid, pink liquid. And so it's not very appetizing, and it's very pasty because of the solid, because mostly it's insoluble. It doesn't dissolve. And that's why it's safe to drink, because otherwise, if it were soluble like sodium hydroxide, you'd be pouring drain cleaner down your throat, which would cause serious damage. And so that's the difference there. There are a couple of drugs available. There's something called sodium EDTA versus calcium EDTA. EDTA is the drug itself, EDTA, and it's not only is used as a drug, but it's also used as a food preservative. And so, which one would be more aggressive drug, sodium EDTA or calcium EDTA? What do you think would be more aggressive? More aggressive meaning, you know, letting EDTA do its job. Yeah, sodium EDTA, just like these two hydroxides, which one is a more aggressive hydroxide? Well, drain cleaner, for sure. If you tried to pour milk of magnesia down your sink, it's not really going to help much, you know, because most of the magnesium hydroxide is a solid paste. And so if you run out of drain cleaner, but you have milk of magnesia in your medicine cabinet, it's probably not going to work. Just like if you ran out of drain cleaner and you have milk of magnesia is probably not going to substitute for sodium hydroxide. What is the milk? The milk is just because of the texture of the stuff. The stuff is milky, what we call milky. Milky solids and milky liquids are like muddy water, you know, just kind of suspension, thick suspension. Milk has a lot of protein, so it's thick. Some milks are too thin, you know. In some countries, they water down the milk. So you have milk and then they water it down. They water it down by adding a whole bunch of water. That way, they had 1 gallon of milk, they can automatically make 2 gallons of milk. And so these unscrupulous people could double their profit, you know, by watering down the milk. And so milk is often tested for protein content. Well, these unscrupulous people wanted to get around that too, so they added things. You know, when they test for protein, they don't really test for protein. They look for things like nitrogen, carbon, hydrogen, nitrogen. And so sometimes they'll look at the nitrogen content to determine how much protein's in there, but you can't just look at nitrogen because lots of things contain nitrogen. So what they ended up doing is they ended up adding melanin. Melanin is like plastic into it, and it happens, unfortunately, the melanin's toxic, so the people were adding toxic melanin to up the nitrogen content to fool the regulators into thinking there was much more protein in the dairy stuff than there really was. It happened in baby formula, unfortunately. But anyway, it's just a texture. That's why they call it milk. There's no milk in there. Don't drink the stuff. Well, you can drink this stuff without dying. Don't drink the Red Devil Lye. That way you may die. And so going back to this, the sodium, yeah, you'd expect sodium EDTA to be more aggressive because the sodium wouldn't be clinging onto the EDTA. Calcium would be clinging onto the EDTA. Why? Because sodium's +1, calcium's +2. So calcium is going to be much more clingy to EDTA and not let EDTA do its full job. So just like this, magnesium is much more clingy to the hydroxides. The hydroxides are what neutralizes the acid. the hydroxides are what breaks up the fats in drain clogs. You know, hydroxide can break up fats by breaking or hydrolyzing bonds in fats, make them more soluble. So let's take a look at this. Take a look at a CDC study here. Well, EDTA is a drug used for lead poisoning or heavy metal poisoning. EDTA loves lead, it loves mercury. It's a good combination. This is from 2003 to 2005. EDTA is used in chelation therapy for heavy metal poisoning. It's called chelating. EDTA chelates the heavy metals like lead. These were lead poisoning. And so, well, EDTA is good because EDTA can get rid of lead in your blood. And so it's called a chelating agent. And so there are two drugs available. There's calcium EDTA. Now the nomenclature system gets tricky. This is called disodium calcium EDTA. This is an ionic compound. EDTA is actually a 4-. You know, I told you 4- is rare, but it's 4-. It's not monatomic. It's actually a huge ion. And so the oxygens, there are 4 oxygens on here with a 1- charge. And so when we add those all up, it comes out to 4-. And that means we can have a lot of different combinations. And so in this case, we have to use a hybrid naming system. Here, this is saying that there are 2 sodiums and 1 calcium. And so that'll give us +4. Calcium is 2+, each sodium is +1. And so that'll neutralize the 4-. So we'll have disodium calcium EDTA. The other one is this, which is just called calcium EDTA. And so, you know, we drop the 2 sodiums. And so this is called calcium EDTA here, the disodium calcium EDTA. Now the other EDTA is sodium EDTA here. Sodium EDTA would have a total of 4 sodiums on there. So it's actually tetrasodium EDTA, but they just call it sodium EDTA for short. Yeah. And so it's Na2 EDTA, but that's not actually correct because they aren't showing the Na2 that's already on there. And so it's just kind of a weird thing they do. But anyway, this is the chemotherapy, a chemical therapy for lead poisoning. What's that? Let's continue on here. So chelating agents, especially those intended for use in children, should be effective in reducing lead and other heavy metals from the body without producing substantial adverse effects. You know, the calcium is critical for healthy functioning of your blood chemistry. And so EDTA loves calcium too. You know, EDTA and calcium like each other. The only agent recommended for intravenous chelation therapy for children is calcium EDTA. Sodium EDTA is too aggressive. You know, we want the less aggressive calcium EDTA. However, hospital formularies usually stock multiple chelating agents. Sodium EDTA, which was for more acute, you know, toxic levels, you know, more urgent, have to bring it down rapidly, versus calcium. So they had an aggressive, you know, sodium EDTA, which is the aggressive form. Sodium EDTA said the use of this drug in any particular patient is recommended only when the severity, so it's only for severe cases of lead poisoning of the clinical condition, justifies the aggressive aggressive measures associated with this type of therapy. And so obviously sodium EDTA, sodium EDTA is like the drain cleaner, and calcium EDTA is like the milk of magnesia, right? So let's go to the case report here. Texas. Texas, in February 2005, a girl aged 2 years who was tested for blood lead during routine health surveillance had a capillary BLL blood lead level of 47 micrograms per deciliter. A venous BLL of 48 micrograms per deciliter obtained 12 days later confirmed the elevated blood lead level. A complete blood count and iron study conducted concurrently revealed low serum iron levels and borderline anemia. On February 28, 2005, the girl was admitted to a local medical center for combined oral and intravenous chelation therapy. So 2 years old. The patient's blood electrolytes at admission were within normal limits. Initial medication orders included intravenous sodium EDTA and oral Sexamer, an agent primarily used for the treatment of lead poisoning. So Sexamer is also a chelating style agent. The medication order was subsequently corrected by the pediatric resident to intravenous calcium EDTA. So there was a mistake in the initial medication order. Sodium EDTA is not supposed to be given to children. It's only supposed to use for aggressive cases. And so the pediatric resident caught this and corrected it. At 4 p.m. on the day of admission, the patient received her first dose of intravenous calcium EDTA, 300 milligrams and 100 milliliters normal saline at 25 milliliters per hour. At 4:35 p.m., she was administered 200 milligrams of oral Sexamer. Her vital signs remained normal throughout the night. At 4 a.m. the next day, a dose of intravenous sodium EDTA instead of intravenous calcium EDTA was administered. An hour later, the patient's serum calcium had decreased to 5.2 milligrams per deciliter. Normal value for pediatric patients is 8.5 to 10.5 milligrams per deciliter. At 7:05 a.m., the child's mother noticed that the child was limp and not breathing. Bedside procedures did not restore a normal cardiac rhythm, and a cardiac resuscitation code was called at 7:25 a.m. The child had no palpable pulse or audible heartbeat. Repeat laboratory values for serum drawn at 7:55 a.m. indicated that the serum calcium level was less than 5.0 milligrams per deciliter, despite repeated doses of calcium chloride to try to replace the calcium that was taken by the EDTA. All attempts at resuscitation failed, and the girl was pronounced dead at 8:12 a.m. So this is tragic. I mean, a 2-year-old girl comes in at 4 p.m. and is dead by 8:12 a.m. the next day. An autopsy revealed no results of toxicological significance. Anyway, this is just too depressing. Pennsylvania, August 2005, a 5-year-old boy, same mistake, sodium EDTA instead of calcium EDTA. So for some people, it makes no difference. Sodium EDTA, calcium EDTA, it's all the same. And the same people will probably think, drain cleaner, milk of magnesia, same thing, does the same thing. Milk of magnesia, magnesium hydroxide, drain cleaner, sodium hydroxide, use them for both, to somebody who knows, a little bit about solubility and this kind of stuff. And, this is just, it's obvious, sodium EDTA is going to be much more aggressive than calcium EDTA. But, to other people who aren't really keenly aware of differences, charges, it looks the same. Sodium EDTA looks the same as calcium EDTA. EDTA is EDTA, isn't it? And so, well, this is only a few, but there have been too many deaths, way too many deaths. And so finally, the end, they look alike, sound alike. So look alike, sound alike is very dangerous in the hospital. And so look alike, sound alike, they're getting rid of that. And so the CDC recommends getting rid of sodium EDTA. And so CDC recommends that local hospital pharmacies evaluate the need to keep sodium EDTA. They recommend getting rid of sodium EDTA. That way, the look-alike, sound-alike aren't mixed up. Okay. But, you know, to a chemist, the sodium hydroxide versus magnesium hydroxide, there's a world of difference, you know, in those two. So there's some stuff on solubility. So you notice like the soluble ones are low charge, like so group 1 are all +1, you know, and the insoluble ones are higher charge, like +2, +3, or -2, -3. You know, those are more insoluble, less reactive, more stable in terms of the compounds that they form. So go back through the solubility rules. You're supposed to memorize these, you know, in Chem 4. I always have my students memorize these. You have to memorize a lot of stuff. You know, the take-home exams make it difficult for me to mandate memorization because a lot of people don't bother memorizing a thing, you know, if everything's take-home. That's a problem because if you don't start memorizing now, then the load gets bigger and bigger. And it makes the more advanced classes harder and harder. So, you know, you might think, I want to just take it easy. I want to kind of be lazy. Well, you're going to be hurting yourself, you know, when the stakes are much higher. The stakes are much higher in the advanced classes than in the beginning classes. In the beginning classes, the stakes are much lower. If you want to go to med school, you know, they're really going to keep an eye on your upper division classes. How well did you do in your upper division classes, you know? And so if you want to go to medical school, you know, which is extremely competitive, then you got to start, you know, now. You start working hard now. It's like a long marathon. You know, a long marathon is everybody starts at the beginning the same. But at mile 10, you know, I don't know how long a marathon is, mile 20, I don't know if they go that long. But people start spreading out, you know, and pretty soon the people at the back can't even see the people at the front. They're so far ahead. This is what's going to happen in school. In school, what happens is the people who are far ahead, you know, are going to be at such a huge advantage over, if you're behind, over you who are behind, that it's impossible to catch up, you know. And so this is what I see this all the time. You know, people fall so far behind, they're never going to catch up to the top students. If you want to be one of the top students, you got to stay on top of it continuously, you know, and then you won't fall behind. It's much easier to stay ahead rather than fall behind and catch up. Falling behind and catching up is hard to do. And so even though you might not think it useful to memorize the solubility rules now, I mean, if you memorize them now, you know, in the future, it'll be a lot easier to recall this kind of information, some of the patterns you might see. Yeah, I do teach Chem 1A, but not next semester. Next semester is Chem 4 again, next year. To answer the question. So that's one. So we're looking for formation of these precipitates. These precipitates have strong bonds. When you get a +2 and a -2, that's much stronger bond than a +1 and a -2, or a +1 and a -1. A +1 and a -1 is much weaker what bonds or holds the ions together. And so the higher the charge of the ions, the more strongly those are held together, and the stronger the bond. For sodium EDTA, calcium EDTA, milk, magnesia, and lye or drain cleaner, we want weak bonds because we want them to react, you know, but not too weak where it kills us. Okay, we're also looking at stronger to weaker acids and as a driving force. So what we do is we consult the Bronsted. This is what we call Bronsted-Lowry acid chart here. And so the strongest acids would be like perchloric acid. Perchloric acid is up here, which is an oxidizing acid. This doesn't differentiate between oxidizing acids and mineral acids, not reducing acids. Some acids might be reducing acids as well, you know, like acetic acid. Acetic acid can be a reducing acid in an acid because of the acetate group. The acetate group can be oxidized, you know. But anyway, looking at this here, we can get an idea. These are what we call the 7 common strong acids. The 7 common strong acids are perchloric, hydroiodic, hydrobromic, hydrochloric, chloric, sulfuric, and nitric. If it's not one of the 7 common strong acids, then we assume it's weak. And so all these other acids are weak here, assumed to be weak. Now there are things called superacids, which are even stronger than perchloric. And there are other strong acids here that didn't make the list. The other strong acids are a lot rarer, and the superacids are a lot rarer. We don't always work with those. So most people just memorize the 7 common strong acids. Now, all we need is to go from stronger to weaker. That's it. Stronger to weaker. Here. There are some tricks to using this chart. There's something called the leveling effect. We have to watch out for the leveling effect for strong acids. Let me just tell you what the leveling effect is, and then we'll try to explain it. We'll try to explain it later, but watch out for the leveling effect. Leveling, 2 L's, I think it's with 2 L's, leveling, or 1 L. I think it's with 1 L. The leveling effect means that all these acids, all strong acids in water have the same strength. And so, like say HCl versus HNO3, HCl is a stronger acid, but you put both of these in water and then they become equal. Like, and I can talk about, when we get to Bronsted, I'll talk about why Bronsted acids, bases. But for right now, we can't, if it's in this, if we're going from HCl to HNO3, that's not a driving force. So if we're going from any strong acid as a reactant to any strong acid as a product, that's not a driving force. We have to go from stronger to weaker. So for example, if we go from HF to acetic acid, then that's a driving force. If we have HF as a reactant and acetic acid as a product, that's a driving force because we're going from stronger to weaker. And so weak acids we can rank. If we're going from nitric acid to acetic acid, that's a driving force, you know, because we're going from stronger to weaker. So as long as we're going from stronger to weaker. However, if we go from strong to strong, we have to worry about the leveling effect. And so this is strong to strong, the leveling effect. The leveling effect is not talked about in our book. However, the leveling effect you can find, if you want more information on the leveling effect, we could find that in Wikipedia. I think, let's take a look at leveling effect. Or maybe the Khan Academy, you know, leveling effect, Khan, Wikipedia, the leveling effect. Is leveling with 2 L's. It doesn't really matter. So what is a leveling effect? You know, lots of sources. So it's not in the book, but it's important to know for driving forces. So that's why we're covering it now. So this is our acid-base chart. And later on, we're going to be looking at the structure and trying to look for patterns in acidity, which we'll find lots, you know, there are lots of patterns. Now, these are the conjugate bases. This is a conjugate relationship. So if we have a strong acid here, its conjugate will be weak. And so these are all bases. Bases want an H, acids don't need an H. That's what Bronsted. So here we look at perchloric acid, its conjugate base is perchlorate. Perchloric acid is a very strong acid, so it doesn't really want the H. That means perchlorate's a very weak base. It doesn't really want an H, you know, to go back to perchloric acid. If we have an extremely weak acid like methane, methane's so weak, most people don't even consider an acid. Same thing with hydrogen. These are exceptionally weak, you know. But if you had a super base, it could pluck a hydrogen off there and lead to methide. Methide is the strongest base on the chart. Methide really wants an H+. It'll take it from anything. It can, you know. The strong bases are, well, hydronium's one more strong acid, but hydronium's formed from these guys here, you know, so this would be number 8, but it doesn't occur alone as in a compound with an ani. You know? We'll talk about hydronium. The strongest base is methide, but these are the strong bases. The strong bases are the soluble hydroxides. So all soluble hydroxides are strong bases. Lithium hydroxide, sodium hydroxide, potassium hydroxide, rubidium hydroxide, cesium hydroxide, calcium hydroxide, strontium hydroxide, and barium hydroxide. Those are all the soluble hydroxides. The insoluble hydroxides, like iron 3 hydroxide, if we had iron 3 hydroxide, we wouldn't consider that a strong base. You know, that would be a weak base. Why? Because it's insoluble. Iron 3 hydroxide is insoluble. You know, you could eat this stuff, probably wouldn't kill you, you know, but you wouldn't want to eat any of these strong bases. That would be trouble. It's also the soluble sulfides. This is called amide, this ion here, NH2-, the soluble amides, the soluble oxides. For example, you could eat rust and you wouldn't die like that. But if you were to eat sodium oxide, you would be in big trouble because sodium oxide is soluble, you know, and the oxide's a powerful base and it could lead to problems, you know, worse problems than drinking sodium hydroxide because oxide is a more powerful base than hydroxide. And so that could lead to more significant damage, tissue damage. So we use this chart. We don't memorize anything. We just use it. And the more we use it, the more familiar we become with it. You know, it's not like we're going to memorize a bunch of stuff. We just use it frequently. And then that's how we remember certain things. Eventually, we'll look at these structurally in detail to see, you know, what makes it a strong acid or what makes it a strong base, that kind of stuff. Okay, then we look at, okay, stronger acid, weaker acid. One of the things is strong acids are strong electrolytes. Weak acids are weak electrolytes. And so weak electrolytes are more stable, you know. And so another thing is the formation of weak and non-electrolytes, you know, is more strong is less stable in this case. This would be a strong electrolyte. All the ions are broken apart. This would be a weak electrolyte. We have some partial breaking apart. This would be a non-electrolyte. There's no breaking apart. So non-electrolytes are very stable, you know, don't want to break apart or do anything. And so that's important for this. Gas formation is another driving force. Gas formation sometimes will form something like this. This is called carbonic acid. Carbonic acid is unstable. Carbonic acid immediately decomposes, and it's going to decompose into CO2 and H2O. So carbonic acid decomposes into CO2 gas and H2O liquid. It's unstable. In fact, not only is carbonic acid unstable, sulfurous acid is also unstable. Sulfurous acid decomposes into SO2 gas plus H2O liquid. These are acid-base decompositions. So H2SO3 breaks up into SO2 and H2O. Ammonium hydroxide is unstable as well. Ammonium hydroxide, these are ion combinations. You know, what ion combinations? This could be an H plus and an HCO3 minus. Or it could be two H pluses and a CO3 2 minus. These are ion combinations that would lead to formation of carbonic acid. So if we have some ions that combine to form carbonic acid, well, it's not going to last very long. Sulfurous acid is not going to last very long. And ammonium hydroxide, if we take ammonium ions and hydroxide ions, that ion combination decomposes into ammonia plus water. Now, CO2 is not very soluble, so it's going to effervesce, bubble out. SO2 is the same. It's not very soluble, so it's going to effervesce, bubble out. Ammonia, however, is quite soluble. And ammonia is either going to be aqueous ammonia or gas. You know, it depends on how much you generate. But ammonia is a little different than SO2 and CO2, which are largely insoluble. Ammonia is quite soluble. This has the other rule, like dissolves like. Ammonia is water-like in certain respects, whereas SO2 and CO2 are unlike water in the opposite respects. If we have hydrogen ions and sulfide ions, it'll form H2S, or two hydrogen ions. If we had one hydrogen ion and a bisulfide ion, then it'll form H2S. You know, H2S is the rotten egg odor gas. It has the smell of rotten eggs, and a lot of bacteria make H2S. You know, sulfur-eating bacteria. Sulfur, remember, is a good fuel, and so sulfur, at least with a -2 charge, you know, sulfur with a -2 charge like that. That -2, how do you get that? Well, if you look at thiols like N-acetylcysteine, NAC, which is the antioxidant. This is sulfur that's the antioxidant there. The sulfur here is a -2 oxidation state. We're going to look at this in more detail later on. And so H2S is just this. H2S is a pretty good reducing agent as well, but it's quite toxic, unfortunately. You can't use this as an antioxidant. This stuff's going to kill you. So it's deadly. Skull and crossbones, that kind of thing. In fact, some guy died. You know, H2S is sometimes associated with oil. You know, oil wells hit a pocket of H2S. Some guy died there in Ventura from H2S toxicity. But anyway, you know, this RSH, you know, in glutathione and also in N-acetylcysteine's antioxidant. And this is something that people take, including me. Hydrogen cyanide is also very toxic. You know, it's a cyanide. Cyanide prevents oxygenation of your blood, you know, because cyanide will bind to hemoglobin in your blood and not let go. It prevents oxygen from hitting there. But when hydrogen ions combine with cyanide ions, you form HCN gas. HCN gas has the notorious reputation of being the gas that was used in capital punishment at San Quentin. San Quentin had a hydrogen cyanide chamber in which they mixed sodium cyanide with acid. They mix sodium cyanide with acid. The acid loves cyanide and forms HCN gas. And they use that for well, an execution basically. And so it's dangerous stuff. You know, so you gotta watch out what you're mixing together, because you can form toxic substances for sure. All right, so let's take a look at this metathesis example here. And some of these metatheses fit a pattern, you know. Some of them are just ions. You're looking for ions to react together. So calcium carbonate plus sulfuric acid. And so when we look at calcium carbonate, is it break time now? Oh, I wish they should need the timestamp. All right, let's go on a break then. That sounds good. We'll go on a break for 15, then we'll come back to the break. So I'm gonna pause recording, or so I'm gonna, yeah. I guess I'll just pause it. Okay, it's time to get started again. So we're looking at calcium carbonate and sulfuric acid. This is a formula. Sulfuric acid is aqueous. If there's water present, well, carbonates are insoluble. Phosphates, carbonates, and chromates are insoluble except for group 1 and ammonia. This is not group 1, that's group 2. So that's insoluble, so that it's solid. This fits a pattern. It's AB plus CD. This is called double replacement. And all we do is we switch over the anions. And so we just try different ion combinations. So this is our current ion combination. A is paired with B. So a new ion combination would be pairing A, the cation, with the anion D. And so when we do that, we have A, the cation's calcium, and the anion for D is sulfate. So we had calcium and sulfate combined, so that would make CaSO4. And then we have the cation H+, and so that's C paired with the anion carbonate. And so this would be CO3 2-. And so we need two H pluses in order for this to work. So it's going to form H2CO3. Okay. One thing we know about H2CO3 is it's unstable. And H2CO3 immediately decomposes into H2O liquid plus CO2 gas. Carbonic acid is unstable and decomposes into CO2. So this is going to effervesce. This is what we call a driving force. A driving force is gas formation. Here. Now, normally sulfates are normally soluble except for silver, lead, mercury, calcium, strontium, barium. And so calcium sulfate is actually insoluble. So this is a precipitate. Normally a precipitate is a driving force, but this precipitate's tricky because we're giving up one precipitate for another. Do you see that? There's one solid for another. And so what we have to do is we have to compare the two solids to determine which is more stable. Is more stable. So we use things like melting point or and actually the best one is solubility. You know, which one is less soluble? Now solubility has a quantitative definition. The quantitative definition of solubility is the maximum amount of solute, that is what you're trying to dissolve, that can be dissolved in a fixed amount of water. And so usually like 100 milliliters of water, you know, how much calcium sulfate can you dissolve in 100 milliliters versus how much calcium carbonate you can dissolve in 100 milliliters. That'll tell us which of these two solids is more stable. Both of them are insoluble, so we can't tell based on that. And so if we were to look at the solubility, the quantitative solubility, you know, we did qualitative solubility, which is it soluble or insoluble? That's qualitative. If we're going to do quantitative solubility, then let's compare calcium carbonate. And so if we go to Wikipedia, let's take a look at calcium carbonate here and go down. This is physical properties here on the right. We scroll down here, soluble in water. And so this is taking a liter of water and you could dissolve 0.013 grams or 13 milligrams. 13 milligrams in a liter at 25 degrees C. So remember that number, 13 milligrams per liter calcium carbonate. Now we're going to search for calcium sulfate. And let's take a look at the solubility of calcium sulfate, which is this white solid here. And so we go here. This is not per liter, this is per 100 milliliters. So we have to multiply by 10 to get a liter. 1,000 milliliters. So if we multiply the bottom by 10, we have to multiply the top by 10. And so if we do that, it comes out to 2.1 grams per liter for the anhydrous form and 2.4 grams per liter for the dihydrate form. And so calcium sulfate is much more soluble in water than calcium carbonate. And so if we go back to our thing here, if we go back to our thing here, this is not a driving force. This turns out to be a more stable, less soluble, according to Wikipedia. And this is less stable, more soluble precipitate. And so precipitation is not a driving force here. You know, this happens when we're doing solid to solid conversion. If this were aqueous and this were aqueous, then there's no question the solid is more stable than two aqueous solutions. You know? But it's not. But all we need is one driving force. So unfortunately, this one doesn't count because this calcium carbonate is less soluble, more stable. But we had to look it up. We looked it up in data table. So this is more stable, less soluble. And therefore, this is not a driving force. We only have one driving force, so it's a gas formation, or two driving forces. The second driving force could be thought of this way. The second driving force is sulfuric acid is one of the strong acids. Carbonic acid is a weak acid. And so what we're doing is we're going from a stronger acid to weaker acid. This is driving force. So stronger acid to weaker acid, sulfuric to carbonic, or gas formation. CO2 is what we call a Lewis acid, and it's also weaker. And carbonic acid is what we call a Bronsted acid here. And so we could look up CO2 on the table as well. Let's take a quick peek at the table. Here's sulfuric acid, and then carbonic acid's here. Carbon dioxide, aqueous, CO2 and water, or carbonic acid, H2CO3. It's quite a bit weaker than sulfuric. So we're going from stronger acid to weaker acid, downhill. So that works. All right, this is called the CE, or the complete equation. For these double replacement reactions, we'd like to do the NIE and the IE. So next comes the IE. Remember, for the ionic equation, we dissociate or ionize strong electrolytes. So calcium carbonate is not a strong electrolyte because it's an insoluble salt. Soluble salts are strong electrolytes. H2SO4 is a strong electrolyte. Strong acids are strong electrolytes, but it's funny how it splits up in electrolyte properties. One H plus breaks off, leaving the other one on there. When we look at HSO4 minus, HSO4 minus is not one of the 7 strong acids, so we don't do a step 2 dissociating this. We just leave it as H plus and HSO4 minus. This is a common mistake that people make with H2SO4. Common mistake is this. Some people want to split it up into 2 H plus and 1 sulfate. It's not right. And then over here, calcium sulfate is insoluble solid, so that's not. And then finally here, H2O is not a strong acid, not a strong base, and not a soluble salt. Same thing with CO2. Yeah. And so this would be the ionic equation. In this case, there are no spectators, so this equals the net ionic equation. And so we have 2 driving forces. Driving force was stronger acid to weaker acid, and driving force was the gas formation. This followed a simple pattern. The AB plus CD was looking at alternate ion combinations for that. All right, this next one, potassium sulfide and acetic acid, is this one we're going to skip. This one. This is a Chem 1A, Chem 1B level problem. It's not appropriate for Chem 4. Skip this. This one's appropriate for Chem 4. This would be an advanced Chem 4 problem, just like the first one. This is lead. Actually, lead iodide, if it's not specified, lead 2 is much more common than lead 4. So if somebody says lead iodide, most likely they're talking about lead 2, not lead 4. Lead 4 is much more rare in comparison. And so lead iodide would be lead 2 iodide, PbI2. And hydrochloric acid. Hydrochloric acid is HCl here. Okay, so again, here we got the HCl is aqueous, so we got water around. Now it's iodide. Chlorides, iodides, and bromides are all insoluble. No, I got that backwards. Chlorides, bromides, and iodides are all soluble except for silver, lead, and mercury. So this happens to be one of the exceptions. Most iodides are soluble, but this is not, therefore it's solid. Okay, again, this fits the AB plus CD pattern. And so what we're going to do is we're going to switch the anions. Pair up A with D and C with B. So we'll take A, which is lead 2, and pair it up with D, which is chloride. And so we'll need 2 chlorides for every lead. So we'll end up with PbCl2. And then we'll take C, which is H plus, and pair it up with I. So we get HI. HI is hydroiodic acid, so that's aqueous. Chlorides, bromides, and iodides are all soluble, excuse me, except for silver, lead. Oh, this is lead. So lead 2 chloride's insoluble, so that's precipitate. Now we have a problem here. It's a solid to solid. So which one is more stable? Which one of the 2 solids is more stable? So what we're going to do is we're going to look at the solubility of those. So this one we have to look at additional quantitative solubility data to be able to figure it out. And so for this particular instance, I'm going to go back and take a look at Wikipedia. And we're going to look at PbCl2 first, PbCl2, and then compare it to PbI2. So looking at the solubility of PbCl2, solubility is 10.8 grams per liter. So 10.8 grams, well, that's quite a lot, you know. 10.8 grams in a liter, you think it's soluble, but this is below the limit, and so we call it insoluble. But you know, 10.8 grams seems like an awful lot per liter. So it's fairly soluble, and maybe it's borderline. Let's try PbI2. If we go to PbI2, what is its solubility? Look at its solubility. This would be let's go to 20 degrees C here. 0.0756 grams per 100. So we need to multiply by 10, top and bottom. So it's 0.7. So we can only dissolve 3/4 of a gram of PbI2. 3/4 of a gram of PbI2 and almost 11 grams of PbCl2 in a liter. And so when we come back to this, PbI2 is a lot less soluble, so it turns out this is more stable. This has a much lower solubility, and so this is not a driving force. But that's okay. We don't need it to be a driving force because that, you know, reactions still may occur here. So this is not a driving force. This is more stable, less soluble. And so we don't say that this is a precipitation, you know, because this would be making a precipitate but sacrificing another one. However, the acids, let's compare HCl and HI. When we compare HCl and HI, we go to the acids chart. And we compare HCl versus HI. When you look at it, it looks like HI is stronger. It is. It's the second strongest acid. So HI is stronger. However, in water, they're equal. And so, you know, we have the leveling effect here. And so they're equal. Even though HI is stronger. But here, basically, this is looking like no reaction. You know, there's really nothing really driving this reaction forward. You know, because we want to form more stable stuff. Therefore equal. It's a leveling effect. So if there's no reaction, you know, no driving force, that's why we got no reaction. There's no driving force. And so we'll just leave it like that. We aren't going to do an ionic equation or net ionic equation for this one. It's not necessary. Okay, let's move on to this one. Hold on just one second. I need to do something really quick. Okay, I'm back. All right, next one is a bit tricky here. This is magnesium nitrate with aqueous ammonia. And so let's do this one next. Magnesium nitrate has 1 magnesium and 2 nitrate ions. All nitrates are soluble, and since this is aqueous, there's water around, so magnesium nitrate would be aqueous. Normally it's a solid, but it dissolves in water. Plus aqueous ammonia, NH3AQ. Now, whenever we have NH3AQ, we have to do something special in metathesis. And so let me talk about that over here. NH3AQ. It's a weak base. And what do weak bases do? Weak bases partially hydrolyze water. Partially hydrolyze. They partially hydrolyze. What that means is ammonia and water react. Water is interesting. Water is both an acid and base, and it's called amphoteric or amphiphilic. It can go either way. And so water is actually on the acid-base chart on both sides of the acid-base chart. If we look at water here, we see it as an acid here. It's a pretty weak acid. It's water. We also see water as a base. It's a pretty weak base. And so water is amphoteric. Any species that occurs on both sides is amphoteric. When you look at this chart, there are a number of amphoteric species like hydrogen sulfate or bisulfate. Bisulfate's an acid. It's a pretty decent acid, but it's a very weak base. There are other amphoteric species here as well. Ammonia. Ammonia is both an acid and a base. It's a much better base than it is an acid. And so we'll see some amphoteric species on here. Okay. And so we have to keep in mind that there's going to be a reaction. Now, what weak electrolytes do is they partially hydrolyze or partially ionize. In this case, they're going to partially hydrolyze. So a little bit, only less than 0.1% does. 99.9% stays like this. But about 0.1, actually less than 0.1% will actually react to form ammonium and hydroxide. Hydroxide is a strong base. Ammonia is a weak base. And so we're going from a weak base here to a strong base here, or a stronger base here. That's not favorable. And therefore, this reaction is favored in the reverse direction. But in kinetic molecular theory, there's always collisions. And once in a while, the collisions will end up forming these higher energy products, you know, like this. Now, this 0.1% is pretty static. It stays like that because the collisions never stop. And what can happen is these ions can react in a metathesis reaction. And so what I'm going to do here is I'm going to take ammonia plus water. And when I think about ammonia plus water, I imagine it as consisting of ammonium ions and hydroxide ions. Ammonium ions and hydroxide ions. And so I use ammonium hydroxide up here, but I don't use it down here because if I went to buy a bottle of this, let's say you went to the chemical store and you bought a bottle of ammonium hydroxide. When you get that bottle of ammonium hydroxide, you'll realize that you only have 0.1% ammonium hydroxide and you have 99.9% ammonia and water. And so you return the bottle to the chemical store and say, hey, I'm getting 99.9% ammonia and water. I wanted all ammonium hydroxide. And it's impossible to get because if you have ammonium hydroxide, they're going to react immediately to form ammonia and water. This is the driving force going from stronger to weaker. The only thing is we get a tiny bit of this product forming because we can't stop the collisions. And so you can't buy a bottle of this. You have to get this and then use these. That's what we're doing. We have this. This is what we buy. And then we're going to treat it as ammonium hydroxide. Now it fits the AB plus CD pattern. So AB plus CD, we're going to switch the anions. So we got magnesium ions, cations reacting with hydroxide. So if magnesium reacts with hydroxide, we need 2 hydroxides for every magnesium. And then we have ammonium and nitrate. And so we're going to form ammonium ions with nitrate ions. Now, ammonium nitrate in solution is no problem. Ammonium nitrate solid, that's a problem. You know, that's the explosive one. but this is aqueous. So the ions are far apart and whatnot. They aren't in high concentrations like in a solid. So I wouldn't worry about an explosion happening here. It's pretty stable in aqueous form. If you were to dry up the liquid water, then yeah, you better start worrying a little bit. Okay. The magnesium hydroxide, hydroxides are all soluble or insoluble. Hydroxides are all insoluble, excuse me, except for group 1, ammonium, calcium, strontium, barium. Magnesium hydroxide is insoluble. This was our milk of magnesia we saw earlier. Insoluble. And so in this case, there is a driving force. Do you see we're going aqueous, aqueous, solid. This is what we call a precipitate. Precipitate forms from aqueous solutions, aqueous, aqueous, liquid. And so this is a driving force. We don't have to compare two solids. And that's it. So all we need is one. So we got precipitation here of magnesium hydroxide. So let's balance this. And we need 2 hydroxides. And so I need 2 ammonium hydroxides. To get 2 ammonium hydroxides, I need 2 ammonias to collide with 2 waters, double everything. And that's going to give us 2 ammoniums over here. So I'll put 2 ammonium nitrates. So this is what we call the CE here. And then I'll do the IE. The IE, we split apart the strong electrolytes. So magnesium nitrate is a strong electrolyte. It's a soluble salt. So we're going to split it apart into magnesium ion and 2 nitrate ions. Ammonia and water is not. Ammonium hydroxide is a strong electrolyte, but that's not what we buy. We buy ammonia and water at the store. So we're going to get 2 ammonias and 2 waters. Show liquids. Magnesium hydroxide is an insoluble salt. Insoluble salts are not strong electrolytes, according to our rules. And then ammonium nitrate, but there's some debate over that. And then ammonium nitrate, which would be 2 ammoniums and 2 nitrates. The debate runs like this: even if it's an insoluble salt, a little bit dissolves. And what little bit dissolves, does it dissociate or does it stay together? And often it dissociates. Okay, here we have some spectators. For example, the nitrates don't do anything. This is ammonia, this is ammonium, so those are 2 different things. So the net reaction, the net ionic reaction is magnesium 2+ plus 2 ammonia plus 2 waters yields magnesium hydroxide plus 2 ammoniums. We can check atom balance and charge balance, you know, 1 magnesium, 2 nitrogens, 2 nitrogens, 6 hydrogens plus 4 is 10 hydrogens. That's 2 plus 8 is 10 hydrogens. And then the charge plus 2 here, and then 2 times plus 1 is plus 2. So this checks out. So this would be the net ionic equation. So this is tricky. Whenever we have aqueous ammonia, we have to treat that as if it's ammonium hydroxide, as if it's behaving as ammonium hydroxide, which it is, but we don't write ammonium hydroxide here. A lot of people will write ammonium hydroxide here. You can't really buy this stuff, you know, because it's unstable. It decomposes into ammonia and water. Okay, those are some examples of metathesis reactions. We'll do some more later, but right now I want to move on to next time. So I'm going to go to part 2. This. All right, we're going to look at acid-base reactions next. So those are metathesis, and we just looked primarily at double replacement, but we just look at ions, you know, what ions like each other. In acid-base reactions, we have Arrhenius. Arrhenius acid is just H+, Arrhenius base is OH-. Arrhenius is not a very useful, these are definitions, called definitions, the acid. This is the most narrow definition, the least useful Arrhenius. Lewis is the most broad definition, but it's not the most useful. Bronsted is probably a little more useful, at least for us, because Lewis is more difficult. And so Bronsted, Lowry are a subset of Lewis. Lewis is comprehensive, you know. Lewis, you aren't going to miss any. But out of that comprehensive list, some of them are Bronsted, and some of them are just Lewis. You can't subclassify them in Bronsted. But Bronsted is a lot easier to work with, so we look at that. And so Arrhenius acid-base reaction is just H plus, anything that has H plus AQ in solution and OH minus AQ. And this would be an acid-base reaction. H plus is the acid, OH minus is the base, and it forms water in this case. H2O liquid. Driving force here is stronger acid, H plus to weaker acid, H2O. Stronger base, OH minus to weaker base, H2O. That's basically it. So let's look at the Bronsted-Lowry acid-base method. Bronsted acids are proton donors. Bronsted bases are proton acceptors, proton being H plus. And so this is proton donor. This is a proton acceptor. The goal is to transfer one proton from the acid to the base and then determine the driving force. Also determine if further reaction occurs. So the method is inventory, like in redox. Determine the strongest acid and the strongest base present. Transfer a single H plus from the acid to the base. Determine driving force, if any. Repeat steps 1 through 4 to determine if further reaction occurs. So let's take a look at this one. This one we could do either method. We could do Bronsted or we could do metathesis. So the first let's do a metathesis. Just for comparison. For metathesis, we assume full reaction, assume complete reaction. Well, we're going to assume complete reaction. So phosphoric acid is H3PO4 plus sodium hydroxides, NaOH. So again, this is our AB plus CD problem setup. And so we're going to try A with D. So that's H plus with hydroxide. Well, H plus and hydroxide make H2O liquid. And then we're going to go C with B, sodium and phosphate. So this is sodium and phosphate. And so we end up with Na3PO4, sodium phosphate. Then we look for driving force. Yeah, there is a driving force here because we're going from a stronger acid to a weaker acid, in this case, water. Also, stronger base, sodium hydroxide, to weaker base, sodium phosphate. Phosphate's a weaker base here, but you just need one. So there's driving force for this, and therefore let's balance it. So we'll need 3 sodium hydroxides to make 3 waters and 3 sodium phosphates. Oh no, 1 sodium phosphate, not 3 sodium phosphates. There. Okay, sodium salts, acids are AQ. So phosphoric acid is AQ. Sodium hydroxide, sodium salts are AQ. H2O is liquid. Sodium phosphate is AQ. Sodium salt again. So that's what we got for this one. So then we could do the ionic equation. This is the CE. For the ionic equation, we break up the strong electrolytes. Phosphoric acid is not a strong electrolyte. It's a weak acid. Strong electrolytes are strong acids, so we leave this alone, H3PO4. Sodium hydroxide is a strong electrolyte. it's a soluble salt. All sodium salts are soluble, even though it's also a strong base. And so we're going to form 3 sodium ions and 3 hydroxide ions. Okay, this is going to go to water. Water is neither a strong acid, strong base, or a soluble salt. And then we go to sodium phosphate. Sodium phosphate is a soluble salt. So we break that up. It's going to break up into 3 sodiums and 1 phosphate. So now we have it. Then in the net ionic equation, we get rid of the spectators. So the spectators would be sodium ions in this case. And so we'll have H3PO4 plus 3 hydroxides yields 3 H2O liquids plus phosphate. And the sodiums are gone. So that would be the NIE for this. Now, for the Bronsted-Lowry, we do it a bit different. So let's take a look. For the Bronsted-Lowry approach, we do an inventory. So we have phosphoric acid and sodium hydroxide. And so the first step is to inventory what's present. Phosphoric acid, we leave alone. We don't split apart. I got it. Sodium hydroxide, we split apart. So there's sodium ions and hydroxide ions. Say aqueous. And then we have water. Okay, then we use a chart. When we look it up on the chart, there's phosphoric acid. It's an acid. Sodium ions are neutral, and they don't appear. Hydroxide is actually both an acid and a base. It's a much better base though. Water is both an acid and a base. And so the next step here is to pick the strongest acid, phosphoric acid, hydroxide, or water, using the chart. When I use the chart, phosphoric acid turns out to be the strongest acid present. What's the strongest base present? Well, sodium ions, hydroxide, and water. Let's assume it's hydroxide, strongest base present. And so the reaction is to transfer 1 hydrogen, 1 proton over. And so this is going to form dihydrogen phosphate and water. Liquid. Okay, if we have more hydroxide, then we can attack the second hydrogen. And even more hydroxide, we can attack the third one. But for right now, we just attack the first one here. In metathesis, we attack all 3, basically at the same time. In Bronsted acid base, we just do 1 with hydrogens, actually. So what's the driving force here? The driving force is H3PO4 is a stronger acid, and then we're going to weaker acid. Which one of these is the weaker acid? Is it H2PO4 minus? If we went backwards this way, it'd be losing a hydrogen, and that's not what we have. So it looks like it's H2O liquid is the driving force. So we're going from stronger acid to weaker acid. That would be that. So again, that was Bronsted acid. This is another Bronsted acid example, acid base example. So try this one out and see what you get. Let me pause it. Yeah. All right, I'm going to end it here, but I'll do a brief recap since I paused it and forgot to hit record. Thanks, Ashley, for reminding me. But, okay, so this one, solid sodium, no, this one, solutions of sodium. I don't know which one I missed. If I missed this one, hopefully I didn't miss this one. Hopefully I just missed this one on the recording. But if I just missed this one on the recording, today has not been a good day for the recordings. There's going to be lots of gaps and holes in it. So hopefully you aren't relying on the recordings alone. But anyway, here we have sodium monohydrogen phosphate and potassium hydrogen sulfate, and there was no reaction for metathesis. But There's a reaction for Bronsted. So in the first step here, we inventory and then we label, sodium ions are neutral, potassium ions are neutral, but HPO4 can donate a hydrogen or can accept a hydrogen. And so it's both an acid base. HSO4 minus is the same. It can donate a hydrogen or accept a hydrogen. Water is the same. It can donate a hydrogen or accept a hydrogen. And so both of these, actually all three of these are amphoteric, both acids and bases. So we just pick the strongest based on the chart, acid, and the strongest base based on the chart, and transfer hydrogen from the strongest acid to the strongest base. So hydrogen goes from the HSO4 minus to H2PO4, so those products are going to be sulfate and dihydrogen phosphate. And then we look for driving force. We want to go from weaker to stronger. And to figure out which one's the acid, which one's the base, we reverse this. So sulfate has to take a hydrogen going back to form HSO4 minus, and H2PO4 minus must lose a hydrogen going backwards to form HPO4 2 minus. And so that's a quick recap, and that's the driving force there. So hopefully that covered it. If it didn't, then there's this one here. And we're going to do more examples of these, so hopefully those will help for Bronsted acid-base reactions. This last part's Chem 1A, and we haven't gotten to Lewis structures yet, or structure in general, and so we can't do this last part of this PowerPoint because we don't have all the tools necessary. Lewis acid base, we can't do those because it relies on Lewis structures. We haven't talked about Lewis structures yet. And this will be an example of a Lewis acid base reaction here. Okay. All right, now I'm going to end the recording. So are there any questions?